Okay, we're back. I hope you enjoyed the two pre-recorded speeches. Lots of interesting data for everybody. And I know we're running a bit late. We're about 50 minutes late, but I think it was a small sacrifice to this nice conversation, nice discussion we had from the panelists. So I go to part two, which is completely different. As I said, it's an innovation that we tried this year. We have 4 different sessions, 4 different thematic sessions. The first one will be presented by Andreas Karakatsanis, will be ER-positive tumors. They're going to be small cases, 1 slide, 1 presentation, and 1 slide, 1 question. And that will be discussed by our panelists. So it's going to be a quicker process and most likely a more interactive process. The second part will be triple negative tumors presented by Yazan. And the third one will be the HER2-positive tumors, which will be presented by Bahadir Giloglu, which will join us a bit later. So how it's going to go, it's going to be the same thing. We're going to have the case presented. It's going to be 1 slide only for the case. So you have all the details you need in 1 slide. And then in the next slides, you're going to get the question. We're going to vote. And then again, we're going to have the discussion. I'm going to give the stage now to Michalis to introduce the panelists. Most of them you have met in the first part, but some are new and they're going to be introduced by Michalis now as part of the part 2. Michalis.
Thank you, Sophocles. So we have a brand new group of panelists now. Let me repeat that the panelists of the first part are more than welcome to stay and act as commentators. But the new ones are Dr. Vasilios Angelis, who is a medical oncologist at St. Bartholomew's Hospital in the UK, in London, in UK. Vasilis, are you around? I saw him before, so he must be here somewhere. Dr. Evangelos Maragoudakis, radiotherapy oncologist at IASO Hospital here in Athens. Hello, Dr. Maragoudakis, welcome on board.
Hi, everybody. Thank you for asking me to participate in this excellent webinar.
Theodoros Kondoulis, a surgeon from Thessaloniki. Theodori, hi again. We'll also have Yazan Mazanad with us. He is doing something right now. He will join in a few minutes. And same goes with Dr. Bahadir Giloglu, who was not here before. He is otherwise, he is somewhere else right now, but he will join in a few minutes too. Bahadir is from Marmara University in Istanbul and a breast surgeon too. And he is the lead of Breastix 24/7, which is the people, the group we worked together with to make this webinar international this year. Let me go on and introduce our first presenter. It is Andreas Karakatsanis from Sweden. And he's going to talk to us about a few cases regarding ER-positive tumors. Andreas, the floor is yours.
Thank you. Thank you very much. Thank you very much for the invitation. Particular thanks for giving me this headache of having to discuss patients with ER-positive disease, where the landscape is a little bit more gray. So I'll just start by trying to share the presentation over here so that we can move forth with that. Everybody sees the presentation?
Yes, we can see it.
Fantastic. So this is me, Andreas. I'm an associate professor of surgery and a consultant at Uppsala University Hospital. These are my disclosures. And before starting, and while you're reading through the case, I want to make it as a snapshot, more or less, so that we can keep clearer messages. I have selected these patient cases. These are real patient cases, just to have a discussion on what is out there literature-wise and how to proceed. This means that I have consciously included wrong alternatives, and I have included more than one correct alternatives just to give a little bit the shape of it. The way that the patients are presented is the way that we think and assess the patients. Unfortunately, and due to GDPR, I cannot have photographic material. So the first case is that of a 59-year-old woman who, by age 34, had undergone mastectomy and sentinel lymph node biopsy for a DCIS. 2 years down the line, she got a right-sided DIEP reconstruction and a symmetrization with a left inferior based pedicle-wise pattern. And now she presents because she's got a multifocal Byrad's 5 lesion that's approximately 7 centimeters with no radiologic discordance, where this is occupying clinically a little bit more than the lateral quadrant of the breast, with more dominance to the lower quadrant, but crossing the midline. At the same time, the core biopsy suggests that we've got an IDC grade 1 to 2, ERPR strongly positive, ERBB2 negative, with a very low Ki 67 in the global sampling from the core biopsies. She is clinically and radiologically node negative, so we are more or less talking about CT3 and no invasive ductal cancer, a luminal A-like type with what we know. Her family history is unremarkable. She's postmenopausal, and in her baseline assessment, we've got no ptosis in her breast. The upper lower pole volume has got 35 to 65% proportion, which means that the bulk of the volume is accumulated in the lower pole. The skin flap thickness following the reduction is 12 millimeter at best. The breast volume, according to Longo formula, is 495 milliliters, and the calculated resection ratio, if we were to go for upfront surgery in this lady, would be approximately 39%. So that's quite generous. She's a busy lady with a demanding job. She's well informed. She's got very clear views, and she wants symmetry and good quality of life. This is what she's predominantly asking for during consultation. So moving further, what would your single best alternative be here? Aromatase inhibitors 12 to 16 weeks initially per the randomized control trials with an ultrasound every 4th week. Aromatase inhibitors with abemaciclib for the same interval but MRI follow-up. Aromatase inhibitors until maximal response with an MRI every 4 weeks. Neoadjuvant chemotherapy. Dual endocrine therapy 12 to 16 weeks with an ultrasound every 4th week, or upfront surgery. Please vote. 10 seconds for that.
Vote now, please.
Yes.
And submit your vote. I think some of the options here are so wrong. I think
Exactly.
you did it on purpose.
Yes, I did.
But you're testing my knowledge here, our knowledge here.
I'm testing the trends mostly.
Yeah.
Andreas,
We're all learning.
Yes.
We are all learning, Andreas, here. We're all learning. We have
Michal, just give me a second. Andreas, since you are also the moderator of your part, so you can actually deal with the panelists and everybody yourself, okay?
Okay, thank you very much.
So you can actually guide the discussion and do whatever you like with it.
Okay, fantastic. So let's get the poll answers. Is it me moving it forward? Yes, fantastic. Okay, so this is as I expected. Without commenting the frequency of responses here, let's go back to what the evidence suggests. So for postmenopausal women with luminal A-like tumors, we know from a meta-analysis of 2016 that neoadjuvant chemotherapy is not more advantageous, and it may manifest a tendency to overtreatment since we are not winning a lot. The randomized controlled trials that have been conducted with the question of neoadjuvant endocrine therapy have been extended to a time window of 4 months, so up to 16 weeks. And usually the most adequate way to assess in these trials was by ultrasound and by clinical caliper, so the MRI was not important. Currently, there is no convincing or any data at all for the concomitant use of aromatase inhibitors and abemaciclib. we could continue aromatase inhibitors until maximal response, but still you need to have a time frame, and the MRI regime is not helpful, especially every 4 weeks, because it will not detect significant differences and will not give you the information that you need. And dual blockade is something that has not shown any benefits over aromatase inhibitors in the randomized controlled trials that have been conducted. Upfront surgery is always an option, but with regards to what we are discussing, neoadjuvant endocrine therapy yields the potential to downsize large tumors. It does not have an adequate potential to downstage the axilla as often, but still it is a valid choice if you wish to perform less surgery. That in this lady's case would be something that she would also prefer. So we are talking about de-escalating from a mastectomy to a complex oncoplastic breast conserving procedure, or in turn de-escalating from a complex oncoplastic breast procedure to something simpler. Good. Let's move forward with.
So what would you do? What would be the answer?
Yeah. So here it is. Here is the answer. Here is what I did, because we're not done yet. So this lady is offered aromatase inhibitors 12 to 16 weeks with ultrasound every 4th week per the randomized controlled trials, which is the best level of evidence that we have available. She gets 2 weeks aromatase inhibitors, but then comes and, because of business and working commitments, wishes upfront surgery. So for that, I would like to ask everybody for their single best alternative. And that's a matter of preference.
Can you read the questions, please?
Yes. So a new MRI for charting and then decision, nipple-sparing mastectomy and SLND with autologous reconstruction with a free flap, nipple-sparing mastectomy and SLND with implant-based reconstruction direct or stage, breast-conserving surgery and senile lymph node dissection with chest wall perforator flap reconstruction, breast-conserving surgery and SLND with new reduction and contralateral DF adjustment. So let's get the results of the voting here. Good.
Would you like one of the panelists to discuss it?
Yes. So I would like some reactions from Michalis and Sophocles to begin with.
I think we should give the chance to somebody else to speak. Maybe Konstantinos. What do you think?
Kostas, what do you think about that?
Obviously, very, very difficult case. So I would rule out a nipple-sparing mastectomy because you mentioned, I think, that she had a previous inferior pedicle mammoplasty. I don't think the nipple would survive a nipple-sparing mastectomy. I don't know if you want to do like a free graft, nipple graft. So I voted for a chest wall perforator because you need to do volume replacement in this case. She doesn't have that much volume in the upper pole of her breast, if I'm correct.
Yep.
It's a very extensive area. So I think this sounds to me like the only feasible option, but it's again a very difficult case.
Yeah, as I said, there are no rights or wrongs. Now sharing my screen, I cannot see all the panelists, but Theo Kontoulis, can you give us your insights on that?
Yeah, I agree with Konstantinos. Would go for a chest wall perforator flap. The only thing you had a key word that she wants symmetry. So symmetry for her is either an autologous reconstruction, a mastectomy and autologous reconstruction, or a chest wall perforator flap, or let's say an oncoplasty with displacement, with a replacement.
Yeah.
So it's either a mastectomy autologous reconstruction to have symmetry, or a perforator flap and symmetrizations.
Good.
And for me also, in your previous, let's say for endocrine, that you tried to do endocrine, she wanted to have a primary endocrine treatment, or you offered her endocrine treatment in order to reduce the extent of resection.
So the initial discussion with this lady was that she wanted to have less surgery if possible. We went through the options. She opted for neoadjuvant endocrine treatment, and then she gave me a call 2 weeks later, and she said, my professional circumstances have changed. I would like to proceed with surgery.
Okay.
And then
So she changed her mind. She
Yeah,
changed her
exactly.
mind because, okay, that's fine. Okay, good.
Exactly. So in this lady, what we actually did is that we went for breast conserving surgery and sentinel lymph node dissection, chest wall perforator flap reconstruction. We got a specimen pathology that showed that she was node negative, so 3 negative nodes, and a total extent of the disease radiologically to 62 millimeters. So it was a T3 N0 M0. So she moved on for postoperative radiotherapy and endocrine therapy as such. Let's move to the next case, and that next case is.
I think, Andrea, sorry to interrupt, but I think Vasilis wants to say something.
Yes.
He raised his hand.
Yeah. The problem is that sharing my screen, I cannot see raised hands. That's the problem.
Don't worry, we're dealing with that. Don't worry
Okay.
about it.
Yeah.
So good afternoon, everyone. I'm Vasilis Agelis. I'm one of the medical oncologists from London, from St. Bart's Hospital. Just a brief comment about neoadjuvant endocrine therapy, because it's something that obviously, as medical oncologists, we don't particularly advise most often. And usually, at least in our practice in the UK, we tend to offer it to people who are too frail to undergo surgery, or they want to defer surgery for other reasons. But I think it's important to mention that despite that, there's ongoing studies that are of particular interest, particularly POETIC, as well as ADAPT. And I think what's interesting in these studies is the use of neoadjuvant reform, more to assess the responsiveness to endocrine therapy that can predict a benefit in the adjuvant setting. Mostly in Germany, where they're actually incorporating Ki-67 quite commonly in their practice, and the patients are given 2 or 3 weeks worth of endocrine therapy, and they're repeating a biopsy to assess the Ki-67 to predict response. POETIC just looked at Ki-67, ADAPT looked at that combined with a recurrence score. So I think we're heading towards potentially an era that we might start using this a bit more often to assess people in terms of their responsiveness to endocrine therapy, and then which could act also as a guide for chemotherapy. And finally, I think it's worth mentioning that we know from phase 2 data that neoadjuvant endocrine therapy in premenopausal women has lower outcomes. So it's something that we don't recommend. Thank you.
Thank you very much. I may as well not show the rest of the cases because you went through all of them now. Good. So the next case is a 64-year-old woman, otherwise fit and healthy. In her right breast, 4 o'clock, a Barrett's 5 lesion, something less than 4 centimeters in extent. You have a core biopsy that suggests a non-specific type ductal carcinoma grade 2, ER and PR strongly positive, ER negative, Ki-67 19% clinically, radiologically node negative, and the PAM50 performed shows an intermediate risk of recurrence. Her family history is unremarkable. Her baseline assessment includes grade 1 ptosis, upper to lower volume ratio 30 to 70%, skin flap thickness approximately 13 millimeters, so not that thick, 325 mLs breast volume, and the calculated resection rate ratio of 1/3 in the breast. She has got wish for breast conservation. So if we move forward with that, we offer her letrozole 2.5 milligrams once daily. What do you do next? And I would like your single best alternative. Okay, let's see the poll results. So most people would go for ultrasound and palpation in 6 weeks. The second choice was MRI in 6 weeks. Some would do ultrasound and repeat biopsy in 2 to 4 weeks, and the list would add tamoxifen to this therapeutic regime. So from the panel, could I ask the opinion of somebody that voted for ultrasound and repeat biopsy in 2 to 4 weeks? If anybody voted for that?
One? No.
Nobody.
So what did you guys vote for? Todoric, what did you vote for?
I voted true because Ki-67 is low. I wouldn't do a repeat biopsy in her in order to see if there's any change. I would just want to see if I could conserve her breast. That is her choice. So I will just see if there is any if endocrine treatment is working. So I will do ultrasound scan and palpation in 6 weeks.
So give her time.
Yeah.
Sorry?
Kostas?
Yeah, I voted the same, like ultrasound scan and palpation in 6 weeks.
Okay.
I think we wanted to see the difference in Ki-67. That would be a reason to.
But it's low anyway, so what to expect?
Okay.
I guess
So-
this is relevant though, because 19% can be perceived as high if your cutoff is 10 to 15%. So above 15%, you could class it as, not low. But I guess what you would be interested in more is to see whether that goes down with endocrine therapy or not. That's what they did in poetic studies and adapt. So I guess that would inform you whether she would be a good candidate for adjuvant endocrine therapy. I guess the question is 6 weeks long enough?
Good, very well. So what did we do? We did an ultrasound and repeat biopsy at 3 weeks. There was no difference in size, and the Ki-67 was 6%. What is the strategy from now on? And I would like to know your single best alternative. No size difference, so you go to surgery. No size difference, so you add tamoxifen. You would continue with monitoring every 4 to 6 weeks, or you could continue with clinical follow-up and monitoring at 4 to 6 months. Could we see the results of the vote? Good, so we are kind of shared between 3 alternatives. Some would go to upfront surgery, some would go for a dual agent treatment, some would monitor every 4th week, some would be more comfortable and would not monitor that often. Good. Any thoughts about that? Anybody from the panel that would like to comment on that?
I would think, I don't know, monitoring at 4 to 6 month interval is a bit too long for me, even for these relatively slow growing tumors. So that's why I excluded this.
Mm-hmm.
Yes. Adding tamoxifen, I have never heard about it. You said that it's not working anyway. Now, we have some evidence that it is working somehow because the Ki-67 has dropped. So my thought is give it some more time, and monitor it closely. That's how I decided to give it some time.
Thank you, Michalis. Yazan has raised his hand, I see.
I don't think that the first scan you're looking for response. You're just looking that it's not progressing, and you will not get any response for at least 4 or 6 months time. So the average time to operate is 6 to 9 months. And if we know that it hasn't progressed after 4 weeks, then we know things are under control. Why to keep on bringing them so frequently to check on something that does not need checking? Just have some faith and see them in 3 to 6 months time.
Good. Okay, Theodore, what are your thoughts?
I agree with Yazan. We don't need to hurry because she's 64, node negative, luminal A. She has a Ki-67 that dropped. We could, and she desires conservation. We could wait. That's the point of doing primary endocrine in her case.
Okay.
We could wait for a few months to see how
Okay.
it goes if it's not progressing.
Good, very well. So the reason that I put these alternatives here, Yazan, would you like to lower your hand because I get confused? So the reason I put these alternatives up here is that the most clinically relevant paper on that is a pooled analysis from the neoadjuvant endocrine trials, the people from Poetic and Impact and Adapt did back in NPJ breast cancer, which was kind of a pooled analysis in order to try to filter out what patients could safely be treated with neoadjuvant endocrine treatment and not close monitoring during the break of the pandemic. So in that study, all patients that had Ki-67 from 5 to 35% were initially included, and the recommendations was that if after a short cure of 2 to 4 weeks you take a new core biopsy and the Ki-67 has gone down more than 10 percentage units or lower than 10%, this is a lady that could safely go for at least 6 months of endocrine treatment without the need of monitoring because it is predictive of good clinical response. And this is what we actually went for in this particular patient. So, interestingly, what we removed in the end was 9 millimeters and she was node negative.
Just by curiosity, the pattern of regression, is it a scatter pattern or is it a circumferential shrinkage of the tumor? Which you find? Was it these little tiny islands of tumor?
No, it was not a scatter pattern. She did not have patchy response. She had concentric response,
which is rare with chemotherapy in these patients, isn't it?
Yes, it is.
Okay.
Exactly. It has to do. So Yazan's point is valid. What you usually see in some of these patients, if you do scanning at 4 to 6 weeks, is that you may see that the size has not changed at all, but if you perform an ultrasound, you see a modification of the desmoplastic reaction around the tumor, and there is the hypothesis that if this is accompanied by Ki-67 reduction, this is a sign of response to neoadjuvant endocrine therapy. And that could be critical because one of the problems with neoadjuvant endocrine therapy is more or less the fact that we do not have the means to select early in order to avoid the waiting period or going to surgery faster and so on. And this was a little bit how we've utilized available evidence in this particular case. So let's move to the next one. And the next one is, I think, more interesting. It is a young lady with a lesion in the lower inner quadrant of her left breast. The radiological extent on conventional radiology with mammogram and ultrasound is approximately 2 centimeters. The MRI reveals a lesion that is 26 by 21 millimeters. She is clinically and radiologically node negative, and we get a core biopsy suggesting invasive ductal cancer grade 2 to 3 perhaps, ER positive, PR positive, an equivocal ERBB2. She is negative on silver in situ hybridization, and the Ki-67 is 17%. She has no family history. Her gene status is negative, and in her baseline assessment, we have a breast of a little bit more than 400 milliliters, no ptosis, the golden proportion between upper and lower volume, skin flap thickness a little bit more, 17 millimeters, and the calculated resection ratio of 28%. She is spontaneously reluctant to getting chemotherapy if this is not absolutely necessary, which kind of lifts the question of if we are not 100% that this lady will be getting chemo, she doesn't want to get it just to be on the safe side. So moving forward with this lady, what do you do next? Upfront surgery, tamoxifen 20 milligrams a day, MRI every 4 weeks, ovarian suppression and aromatase inhibitors with an MRI every 4 weeks, neoadjuvant chemotherapy, Oncotype DX, or PAM50. Okay, nice. Let's go for the poll results now. Good. So most people went for choice one, and I'm very happy for it. There is nothing wrong with upfront surgery. Looking into the outcomes, so neoadjuvant endocrine treatment in women that are pre-menopausal does not yield that significant evidence and does not yield the same efficacy profile, so it is not something that we would commonly do. Rendering her post-menopausal just to give AIs is not something that is either evidence-based. The neoadjuvant chemotherapy could be a case if we had to discuss something, and there are some people that have answered about the Oncotype DX and none about PAM50. So if we just focus on these two particular gene signatures, Oncotype DX could have given us information, but Oncotype DX is not validated from core biopsy samples. So that is a restriction over there. PAM50 is validated on core biopsy samples, but it has not been validated for premenopausal women. So that throws it away, kind of. So this lady moved forward and she had surgery, wide local excision, volume replacement with a chest wall perforator flap, sentinel lymph node dissection. The size of the specimen, which I have forgotten here, was 32 millimeters, negative margins. It was a grade 3 invasive ductal cancer, ER positive, PR positive, and ERBB2 negative with a Ki-67, a global Ki-67 of 24%, 2 out of 3 macrometastases. Systemic treatment, your single best alternative on that.
Can you read the options?
Yes, chemotherapy and then tamoxifen for 10 years, chemotherapy, ovarian suppression and AI, and then tamoxifen for a total of 10 years. Abemaciclib with ovarian suppression and aromatase inhibitors for 2 years, and then continuing suppression and tamoxifen for 3 years. For chemotherapy, abemaciclib, suppression, and aromatase inhibitors and denosumab. Can we get the poll results for that? Good, so there is a tie between chemotherapy, ovarian suppression, and AI plus tamoxifen and chemotherapy, abemaciclib, GnRH analogs, and AI plus denosumab. So
I think, shall we get Mr. Angelis to comment on that?
exactly. I would like the oncologist of the panel to comment on these alternatives and what the best available data is.
Just to go back to the fact that she's 41, so we assume she's premenopausal. Now, what's important to clarify is the grade, because I think you said it's 2 or 3, and I think that makes a massive difference.
It was grade 3 on specimen pathology.
Grade 3. So that even gives a higher, in terms of, benefit of chemotherapy is obvious for a young woman like this. And you could use Predict Breast, the tool that we use quite commonly in the UK, to estimate that and demonstrate that to the patient. I think for a young patient like her, we would be offering her chemotherapy, and we would be using the usual anthracycline plus Taxol regime. Now, with regards to the endocrine therapy, according to the Monarchy trial, she has 2 nodes positive, and her tumor is grade 3, and that's what basically makes her eligible to fit the criteria for abemaciclib. To receive abemaciclib, now you can argue with this if you should offer her a combination of ovarian function suppression. We tend to use goserelin every 4 weeks for younger women, combined with exemestane, aromatase inhibitor, together with abemaciclib. We would offer her, if she manages to tolerate the combination and there's no questions about tolerance, we would carry on and then offer her zoledronic acid as well, rather than denosumab, and that would be a total of 3 years with 6 monthly infusions. And in essence, the data that relate to the choice of offering her ovarian suppression and aromatase inhibitor come from soft and text. Although she doesn't exactly fit the age through which the benefit was shown more evidently, because it was below 35, we tend to extend that to this population. So based on the data from the soft and text, if she did have any other features that were concerning, any lymphovascular invasion, the sample, for example, then that would give us more of a push to offer that. So routinely we would offer her OFS, AI, abemaciclib, and Zometa. But there is a small population of patients that may not be able to tolerate the Zoladex and the letrozole, which would then disqualify them from receiving this.
She's a tough Viking lady, so she will tolerate everything. Don't worry about that.
Yeah, okay. But if they couldn't, I think you could potentially think about tamoxifen in that case, and you could still, consider abemaciclib, but we tend not to.
Okay. Despite that,
Andreas, can I ask a quick question
Yes, of
can
course.
I address one question to Vasilis, if that's all right?
Yeah, of course.
Is it because there's an option of giving abemaciclib without chemotherapy? Is it something we do?
So again, the majority of patients in monarchy had received chemotherapy. You can, in practice, you can argue that if a patient is not fit to receive chemotherapy, I think in that case we do give them the benefit of doubt and offer them abemaciclib. It's difficult sometimes if you stick to the actual rules that you have to follow to offer this drug in the NHS for us in the UK, and but technically, you know the benefit will be there for these patients. So if you have a patient that cannot receive chemotherapy because they're not fit enough, then I think you probably should consider it, as it obviously shows a benefit.
Thank you.
Thank you very, very much about that. So the whole twist with this case was that we did not have a very clear indication to discuss chemotherapy in the preoperative setting. We had a patient that was not willing to get it, if not absolutely necessary. So we needed to move a little bit forward. And yes, surgery first. There is no shame in that. We are not getting any. We are not depriving her of any options. So let's move to the fourth case. And again, it is a lady with no previous history. She now presents with a right breast lesion, retroareolar with nipple retraction, a BI-RADS 5 lesion, something less than 2 centimeters, and a single mobile palpable node on on palpation and ultrasound. Core needle biopsy suggests a classic invasive lobular cancer grade 2, ER positive, PR positive, ERBB2 negative, and a lazy one with a Ki-67 of 9%. The FNA from the node will show us a metastasis. We perform an MRI since this is a lobular cancer. It shows that it is a 30 millimeter lesion that has radiologic nipple invasion. So the nipple retraction is not only because of the desmoplastic reaction, but it is because it is there. In her baseline assessment, we have grade 2 ptosis, upper lower volume ratio 30 to 70%, a skin flap thickness of 2 centimeters, breast volume is 720 milliliters, and the calculated resection ratio is 12%. She is afraid of getting lymphedema. She would prefer to preserve the nipple areola complex. So given these things, what is your single best alternative? Upfront surgery, wide local excision with axillary nodal clearance. And when I'm saying wide local excision, I'm not limiting any type. We could discuss oncoplastic or not there. Upfront surgery with wide local excision and primary targeted axillary dissection by clipping that single node, clipping the breast and the node and offering neoadjuvant chemotherapy, clipping the breast and the node and giving letrozole for 12 to 16 weeks, or clipping the breast and the node, giving letrozole until maximal response. Please vote. Let's see the results of the vote here. So most people would clip breast and node and start on letrozole for 12 to 16 weeks, followed by those that would clip breast and node and give letrozole until maximal response. Okay, let's start exploring these options here. So anybody from the panel with some thoughts on what is the reason behind each strategy and what are the expectations? Fyodor?
Sophocles, you want to?
No, it's okay. Carry on.
Okay, so here I think that the dilemma is to do surgery, which the guidance is to do clearance. We have a key word that the woman is afraid of having lymphedema. So we might want to do TAD, but there is no guidance for TAD in upfront surgery, and or to do endocrine treatment. We could try endocrine treatment in order to see if there is any response, but because it's not a very clear case, we have her desire, but we have also the guidance what to do.
Okay.
So I'm between 1 and 4, to be honest.
Okay. Sophocles, what are your thoughts?
So I said, well, the patient here has a couple of needs. One, to preserve the nipple areola, and we have
That's
a
wish.
tumor that is
You-
deep behind the nipple. So if you're going up from surgery, you're going to sacrifice most likely the nipple.
You
And-
will. It is involved.
Yes.
We know it from
And-
radiology.
And secondly, you will need to do something to the axilla. So we forget up from surgery from this point of view. And then if we go to neoadjuvant, I think maximal response, this is what I voted. I voted for 5. You never know how much, if you follow them up, you'll see how it goes. And I think they will get this maximum response between 6 and 8 months. So I think it's a bit more than the 12 to 16 weeks I guess. Well, that's why I voted for 5, but I think even 4 would be a viable option. 4 and
Okay.
5.
Dr. Natsiopoulos, any thoughts on that?
Yes, of course. The problem is that the patient needs to preserve the nipple and also to avoid lymphedema. What about the data for axilla management after NAC with endocrine treatment? There is no data. And a possible problem is that the positive lymph node has a minimum possibility to response, complete response. So if we go with upfront surgery, maybe we could spare the axilla with 1 or 2 nodes positive and stay in sentinel lymph node. After NAC with hormonal treatment, with 1 positive lymph node remaining in the axilla, what have to do? It's a question.
Very well. So
I
think
don't think we could possibly have the 2 necessities of the patient. Okay.
and
I think, sorry to interrupt, Andreas, but I think there's a recent paper about those people with clinically node positive axilla who are going in upfront central lymph node biopsy as part of Z11. They're getting worse outcomes than expected. I'm not sure if you're aware about this meta-analysis, but I think it's quite a question about whether the safety of this approach is good now.
yeah, I know I chose that one because that's a tricky one. So just to put some more spice in the discussion, in the 2 last recent versions of the NCCN guidelines, primary targeted axillary dissection in patients with solitary nodes has been approved as an intermediate first step in order to be able to see if this was a patient that could adhere to the population of Z11. So one could perform a primary targeted axillary dissection just to see if you really have 1 or 2 metastatic nodes, so if the patient could be spared further surgery. With regards to how to treat the positive axilla post-neoadjuvant endocrine treatment, we can all agree that the landscape is very misty in this sense, and that there is no clear evidence. However, there is a continuing trend, especially in the states that have been implementing more neoadjuvant endocrine treatment than in Europe, to downsize and downgrade in some cases, downstage the disease, to discuss on that. And they have seen that there is no oncological benefit from completion axillary clearance if the patient fits the criteria, but this has been demonstrated in institutional or multi-institutional observational data. There are some publications on Annals of Surgical Oncology last year on that. So with regards to what we decide to do, we need to be aware of what we expect. And I think that if we are a little bit more oriented to the biology, and we discuss with Mr. Angelis, he will also tell us that we are not expecting miracles due to that we have a lobular cancer, we have a luminal A biology, we have a response rate that is somewhere between 7 to 9% when it comes to axillary conversion in the practice of these tumors. What did we do here? So we went for that, and she got letrozole. She got it totally for 12 weeks when we reassessed her. 80% volume-like response in the axilla, in the breast, and the axilla has now converted to clinically node negative. So what is your next response here? Would you continue until radiological complete response? Would you continue with wide local excision, removing the footprint and the nipple areola complex and doing an axillary dissection? Would you do a wide local excision, removing the rests, sparing the nipple areola complex, and performing a targeted axillary dissection to begin with? We are talking about intentions now.
Andreas, sorry to
Yes.
ask, when you're talking about negative axilla, you repeated the biopsy. What do you have done?
No, we have repeated ultrasound, and we have repeated MRI and PET scan. Yeah.
Okay, good. Okay.
So it's MRI imaging, nuclear imaging, and
Okay.
and ultrasound.
Mhm.
Let's see the results.
Yes, let's see the results here. Okay, so most of the people would go for the concept of response adapted surgery. We would remove the rests, we would try to spare the nipple areola complex, and we would perform a targeted axillary dissection. Any thought about our expectations here? What do we expect, and how certain were we when we attempted targeted axillary dissection based on our findings? Just a little bit to build up on the comment Theodore did. So can you tell me what I told the patient before surgery? Yazan, can you guess what I told her?
I think I don't know what you told her. I hope you spoke to her in Swedish because she'll understand you better. But I think there's a bit of expectations because complete pathological response with primary endocrine treatment can happen, but it's not common to happen. So what percentage will you quote them that yes, we were expecting the axilla to completely resolve? And the second thing is, yes, most of us voted yes, we'll try to keep the nipple areola complex, but in reality, how many of us, when we have the patient in front of us, will do that? I'm more comfortable, for example, if it's touching the nipple, to remove the nipple and keep part of the areola, but it depends on the whole setting. So I'm sure you will tell me what you told the patient now.
Yeah. So what I told her is that, so what does the literature suggest? We know that lobular cancer means absence of E-cadherin expression, which means that both the ultrasound and, due to low Ki-67, the PET are not very sensitive in detecting a lot of changes, and absence of radiological disease does not necessarily translate to conversion on a pathological level. The MRI, well, we know that the MRI is a very poor modality to assess the axilla. It has got positive predictive value, but nothing more than that. And if you wonder why we did it because it was a lobular cancer and we wanted to monitor the breast a little bit better, of course. So my discussion with patients when it comes to things like that is that I try to convey the importance of what the test here is pathology. It is not radiology. So if she wants to make an effort to de-escalate surgery, then we are happy to do it. But I had actually informed her that no matter what it looks, you have to consider that your chances is that it's 90% certain that you're going back for an axillary procedure if we see more extensive disease in this setting. She decided to go for wide local excision to try to spare the nipple areola complex and the targeted axillary dissection herself as well. Yazan.
So one other thing is most of the ductal, when you see positive axillas, you have lots of abnormalities on the scan. But
Yes.
it's not uncommon for a lobular to have completely normal scans, and you have 25 out of 25 positive nodes because
Exactly.
cells are smaller, they just go through the lymphatics easier. And the other problem is that sometimes you might need to do immunohistochemistry to be able to assess the extent of the problem for the lobular carcinoma. It's not always straightforward, if that makes sense.
Yes, yes, but this is why I chose this case. I didn't want to make it straightforward. So let's move further on. She undergoes surgery. She's got a honeycomb patch scatter pattern response, 27 millimeters, negative margin, so the nipple areola complex has been saved, and we perform a targeted axillary dissection. 1 out of 4 nodes, which was the index node, still has some residual metastasis. I am not discussing micro, or sub-micro metastasis because this is a definition we extrapolate from the upfront setting and post-neoadjuvant treatments. It is not the same thing. So what would you do here for locoregional treatment? Axillary lymph node dissection and breast radiotherapy, or locoregional radiotherapy? Please vote. We are talking about locoregional treatment only, not systemic treatment.
And we have the poll box, please. Okay.
Can we get the results? Ooh, that's a nice one. So, which panelist voted for locoregional radiotherapy only?
Yeah,
I think
myself.
we should consult our radiotherapy oncologist. So,
Yeah.
Vangeli,
Yes, I
Dr.
vote.
Maragudakis.
Yes, I voted for locoregional radiation therapy. And the reason is that since we have only 1 lymph node out of 4, we can cover the remaining lymph nodes with radiation therapy. Since we have to irradiate the breast as well, then it's one treatment to cover both. That's why I didn't vote for axillary lymph node dissection, because we have 2 different modalities to apply. And it seems to be more complicated. At the other hand, we know that the locoregional radiotherapy can cover the possibility of micrometastasis to the remaining lymph nodes.
Thank you very much. Dr. Natsiopoulos and Yazan then after that.
Okay, I think in that case, it's a tricky case, of course, because the patient has particular necessities. I think that we could assume probably that from diagnosis was only one invaded lymph node, and we can assume it because with the pattern of response, with a scatter response to the breast and one lymph node remained positive, I think that primarily it was only one lymph node invaded. So for me, axillary dissection is out of use.
Yazan?
So this is like a Dr. Jekyll and Mr. Hyde scenario.
Yeah,
So
I know.
if you started and did not know that the axilla was positive, and you've done a sentinel node biopsy, then you have 1 positive node out of 4, and you'll apply the Z11 and say, we'll do nothing. But now, because we knew it's before, we want to treat. That does not make any sense.
Yeah,
So
I
be
did not
comfortable
want
to
give
do
you a-
nothing. I'll be comfortable to do nothing, but I know that locally, many times they end up playing with the fields a bit and they treat at least the lower part of the axilla.
So you see, we had this discussion with Sophocles that we did not want to give you an easy Saturday. You have to work for that. Sophocles, what are your thoughts?
So my thoughts are, and we know that this case, by giving endocrine treatment, gets out of all the data that we have from the randomized control trials, from Amaros, from Z11, et cetera, et cetera. On the other hand, we don't really expect that one lymph node would disappear, and we don't really expect that there were 4 lymph nodes and they shrunk down to 1 lymph node. So what she had from the beginning is what she's having now. And what we would have done initially was to take out just 1 node or 2 nodes if they were negative, to do nothing. I don't think that endocrine treatment should change our plan, despite the fact that we don't have evidence. I think we should treat this patient as if they never had some neoadjuvant treatment before, in terms of the management of the axilla talking.
Okay.
But all this without evidence.
Yeah.
This is
Or-
I don't know if you agree with me.
or with observational data, so to say.
Yes,
but-
yes.
But this is not the important thing. I think that we are more or less on the side of skipping axillary lymph node dissection for this one, since we are agreeing on locoregional radiotherapy. But the interesting thing for me is that I would like to go further on and ask, what is your single best alternative for systemic treatment here? So please give me your thoughts about that. Chemotherapy with abemaciclib and aromatase inhibitors in 7 years, Oncotype DX on the core biopsy sample, aromatase inhibitors for 5 years and biphosphonates, Oncotype on the specimen and aromatase inhibitors in sequence with tamoxifen for 10 years, PAM50 on the specimen, aromatase inhibitors for 2 years and then TAM for 3 years, or PAM50 on core biopsy and sequential endocrine therapy for 7 years, followed by denosumab or biphosphonates. Please vote.
Getting more complicated as it goes, isn't it?
Yes, yes, it is.
You see, this is what endocrine treatment, neoadjuvant endocrine treatment gets all the patients out of the studies.
Yeah.
Out of the range of studies.
This is why we need to work on that study-wise.
Yeah.
So let's discuss the outcomes. What are? How did we vote? Can we get the poll results, please? Wow. Yes. So 1/5 would go for chemotherapy, abemaciclib and aromatase inhibitors for 7 years. Somebody would have done Oncotype DX on the core biopsy and then go for 5 years with biphosphonates. Most people would have done Oncotype on the specimen and then just limit themselves on endocrine therapy for 10 years if that was relevant. Some people would have done PAM50 on the specimen and gone if low risk for 5 years of sequential treatment, and some people would have gone for a PAM50 on the initial core biopsy with sequential endocrine treatment in 7 years, and then some bone treatment. Mr. Angelis, what are your thoughts on these alternatives?
So again, this lady, assuming that she's again grade 1 or 2, she is node positive, but she's postmenopausal, so she fits again the criteria to send for an Oncotype DX score. So I think that would take priority over PAM50, although PAM50 is a reasonable alternative test in non-negative patients. That would be interesting to see in terms of what would be the case. Obviously, if there's an indication that her score is high, she would require chemotherapy. But if not, then in a node positive patient, you would actually, what we tend to do now is, rather than take them over to 10 years of an aromatase inhibitor, because she should have an aromatase inhibitor to start with because of being postmenopausal, we tend to limit it to 7 years based on the data trial. So we tend to offer them at least 5 years, then extend it to 2. And patients that have no problems with osteoporosis, bone health, other issues, you can consider it, but there's no evidence so far that beyond 7 years to 10, they would gain additional benefit. So I think in my case, you'd probably give her, do an Oncotype, offer her an AI for up to 7 years. And now that what we tend to do, at least in the UK, is we offer bisphosphonates to patients that are high risk that require chemotherapy. That's what the studies did. Of course, at the time, these studies did not include patients that had high Oncotype scores. And sometimes there's always a debate about whether patients should have bisphosphonates even if they don't have chemotherapy sometimes. But it's something that you can consider for patients that have concurrent bone health issues as well.
Okay, fantastic. Where would you want the Oncotype to come from?
So this is the key thing, and I think it's validated in core biopsies, to my understanding, and we tend to send the core biopsy if they've had endocrine therapy and use that as our directive.
Well, it is formally not validated. That's the problem, and the practice is that you can send it, but you get the response in the small letters that it is not formally validated. So this is what the conundrum is here.
We still do it because it's not reliable if they've had endocrine therapy, I'm afraid. Yeah.
Good. Dr. Natsiopoulos has raised his hand.
Yes, about the same question. To my knowledge, I think that after treatment, post-neoadjuvant treatment, oncotype DX in the specimen of surgery is not allowed because of the treatment. So the only option, even not validated, is the oncotype DX to the core biopsy specimen.
Good. What about PAM50?
PAM50, I don't think is validated for patients with positive lymph nodes. And that,
Well, just to give the context of the data, it has been validated as part of the CALGB 9741 Alliance trial back in 2015.
Anyway, we don't have any experience with PAM.
Yeah. I'm not talking about, you know, a specific national practice. This is why I wanted to discuss all the available evidence, just to give an outline of how it works. Yazan?
So,
You have your hand up.
can you hear me?
Yes, we can hear you.
That's great. So I have no clue about the PAM50. Now, as you know, we cannot use the oncotype DX on the post-treatment with the letrozole. The other question is, how many oncotype DXs you have found that have a high result on a lobular cancer? I think we audited our results, and I think nearly none, unless they have a pleomorphic lobular, will show a high result. Most of them will have very low result. And then you end up, if you put the numbers of these ladies, I've just put them in predict. If you assume it's a grade 3 lobular, not a grade 2.
It's a grade 2 lobular.
So if it's a grade 2 on predict, she will have, for the 3rd generation chemotherapy, she will have nearly 5% benefit. That's on predict, but also predict does not tease those to lobular and ductal. And you'll have that most likely also from that oncotype DX will be low because she's responded also really well to her endocrine treatment. So you'll have that low oncotype DX to tell you no chemotherapy. You'll have a prediction telling you, oh, she might be benefit from chemotherapy. And I'm not sure that any of those will differentiate between ductal and lobular. So the decision will be a bit of a mishmash of information that you put together. So will she benefit from chemotherapy or abemaciclib? I'm not 100% sure, but will that be offered to her? I think it will be.
Okay, good.
I guess the reality is that TaylorX have never released the data according to lobular or ductal, but I think there have been real-world studies that looked at that, and there's still a percentage of patients that score high, but it's quite low. It's something like 5 to 10% of patients.
Yes, exactly.
It's very low, and it's usually the ones that are pleomorphic lobulars more likely to score that high, and it's more likely to be HER2 positive. Some of them even have ER negativity. But I agree with you. I think we had a look at our data. I don't have the results, and a very low percentage that had high oncotype DX.
Okay, and I have an impromptu question for the panel. How many of you feel that you could not make a decision on systemic treatment without a gene signature? So how many of you feel that it is necessary to have some type of gene signature, even not an optimal one, because it can be clear that, I mean, if oncotype DX is adequately validated for core biopsy specimens, then PAM50 is as well validated for node positive patients. This is where the evidence is more or less. So how many could make the decision without a gene signature? Yazan? He's not there. Dr. Natsiopoulos?
Oh, he should be there because he's talking in a second.
Yes. I'm talking in a second. So we will follow the guidelines, and if the MPI is above 3.6, I think, or 3.4, we'll always do the oncotype DX, and that will aid the decision. But many times we'll make the decision without that, and if there's a clear-cut indication, and even if somebody is in that gray zone and needs to have the oncotype DX, if the oncologists want to give chemotherapy, and if we're not comfortable and want to give the chemotherapy, we will save that £2,000 and just go ahead with the chemotherapy. It's a tool. It's a tool. You need to use it to guide you. You don't use it only that's not the only way of making the decision.
Okay, Dr. Natsiopoulos.
I would be nice without an oncotype or PAM50 gene signature to give post-neoadjuvant just hormonal treatment in this case.
Kostas.
So, okay, I will echo what the other panelists said, but anyway, in Manchester, we don't have funding to do oncotype for node-positive patients yet. We're trying to get that. But ideally, if we were to do it, we would do it in the core biopsy because it would have been affected by the endocrine therapy. In a case with lobular cancer, I wouldn't expect a high oncotype score, and I wonder how much, it would actually help. This is my view.
Andreas, can I have the final word?
Yes, please.
I'm stealing it from anyone else. Because we're gathering some data to write something, there are specific combinations of clinical and histopathological and demographic data that can very accurately predict what oncotype or endopredict will say. And this happens more often than what we think.
Fantastic.
That's what I want to say.
Yeah. I think that I might be working in a parallel project similar to that without confirming or denying that. Thank you very much. Thank you for the attention. I think that we need to move forward with the triple negative session now.
Thank you, Andreas. Thank you for all those tricky questions you put for us. And we move on right now to Yazan, who I hope is with us. And you all know Yazan is a consultant oncoplastic surgeon in the Aberdeen, and he's going to present a couple of triple negative cases. We already saw the first part, which was mainly triple negative cases. We're going to some questions that we didn't address this morning. Yazan.
I was talking to myself and I was muted. So thank you for having me. So I have 3 or 4 cases. We'll see how many we can go through in the next 45 minutes. Can you see my slides? Yeah, you can see my slides.
Yes, carry on.
So there is no conflict of interest and there's nothing to disclose about regarding those talks. So it's 44-year-old female lady, premenopausal, an A-cup breast with a 2-centimeter lump, vaguely palpable. It's a P3 lesion. And the mammogram showed a 21 millimeter lesion, and ultrasound scan shows it's about 18 millimeters. And the axilla seems to be normal. She has no family history. The core biopsy showed invasive cancer, ductal NST, grade 3, ER negative, PR negative, HER2 +1, and it's a basal phenotype. So I think we wanted to put the question as what is the most, if you're going to choose one of those tests, which is the next step that might change your management? And we'll talk about why. So do you want to vote for those 3?
Yes, can we get the voting box, please? 3 options. Which is more important to change the management, MRI, genetics, or staging? Can we see the results? The results, please. Yazan.
So that's not a question for me. I know what I've done. I've done most of those. But anyway, for the panelists, what's your thoughts? Will you go for further imaging with MRI scan, or will you do genetics? Which is the one that will make it more, if you want to have the result now, which one will affect your decision making more?
I think Mr. Angelis might be able to answer the question.
I think the real world answer to this is that by the time you get a response from genetics, it will be 12 weeks. And in that time, you basically do your MRI and your staging as the patient's going to have neoadjuvant chemotherapy. But if in an ideal world you could have the answer of all of these, I think to my eyes, although she's quite low risk, although we tend to stage these patients that will have neoadjuvant chemotherapy, technically she doesn't have high risk enough to be staged. She's not node positive or has a very big, large tumor. So in the immediate situation would be, I think for me, an MRI, just to make sure that there's no bilateral disease or any occult disease that we need to biopsy that could potentially change the surgical modality. Because even if she's BRCA positive, she can have a discussion about prophylactic surgery down the line.
We will get the results if we fast track the genetics in 3 weeks now.
Yes, unfortunately, we don't have that luxury, so it would take longer for us, but yeah.
Andreas, any comments about yours from your side, if you're still there?
I'm here. I just lost the demographics. So if you can repeat the demographics of the patient just to be on the safe side.
She's 44-year-old. It's a 2 centimeter. It's a cup breast, so quite small breast, and it's triple negative basal phenotype. Axilla is negative.
Yeah, well, I can get the genetics in 1 to 2 weeks, so that's usually what I would do. But I do not particularly care about the 2 centimeter cutoff. This is a lady that would undergo neoadjuvant chemotherapy, even if it were 18 millimeters. So to say. Okay, so I would like to discuss. Since this is clear, I would like to discuss expecting an increased breast density due to age and MRI, as Dr. Angelis suggested, and the genetics would be done. But it is very clear for me that this is a lady that would undergo neoadjuvant treatment no matter what.
So, because some people will say T1C, you can start with surgery first, and we have always those discussions.
That's an interesting thing to say, because if we kind of refer to the creatics that started, the big wave for neoadjuvant chemotherapy, T1Cs, they did not have statistical significance in terms of gains, but interestingly, the hazard ratio was the exact same that it was for the HER2 positive patients in the Catherine trial. It's just that the subgroup of the CREATE-X that were T1Cs in the trial were much less. So it was approximately 180 patients, and that would explain the wider confidence interval. But the trend is the same. It's a hazard ratio of 0.67, and
So
we see it in observational data. And then there is another thing. Thinking oncologically, this is a lady that is going to get chemotherapy anyway. So we are there. We are discussing about very viable options to preserve the breast if she undergoes neoadjuvant chemotherapy. So I think that this is a very clear-cut question here.
So let's see, because it's clear-cut for you and for many people, but it's not clear-cut for everybody. Let's see what everybody think about that. So would you start with neoadjuvant systemic treatments, or will you go for upfront surgery for somebody who has a T1C, maybe a T2, but it's looking like more likely to be a T1C cancer, which is node negative? Let's see the results. So most people will go for neoadjuvant systemic treatments, and the people that don't feel that they're comfortable with neoadjuvant systemic treatments, this is a lady that has an A-cup breast in the presentation. So taking a 2 centimeter lump from an A-cup breast, it's quite a large amount. So if you want to give her a better aesthetic outcome, you're going to give her chemotherapy up anyway. So why not to give it up front? You'll excise less from the breast. Anybody from the panel wanted to start with an upfront surgery? Nobody's confessing.
Yazan.
From Yazan, from the surgery point of view, we want to check in a few weeks' time to see if she's BRCA1 also, because she's triple negative. So why not to wait? If not for biology, for the surgery point of view.
Apart from the surgical standpoint, we have to consider something else. The important treatment for patients with breast cancer is their systemic treatment. So what we as surgeons do is necessary, but more or less auxiliary. So if you have a young lady with a small breast that will probably ask for a reconstruction, what you're doing with upfront surgery is that you are going for a larger procedure has higher complication risks. Higher complications risks come with systemic therapy delay, and this is what is going to affect her survival outcomes. So
But one comment, Andreas, before we go to the second patient, if you look at the guidelines, if you look at the ASBRS, and if you could look at the ABS guidelines, they see for the T1C, if it's node negative, then you can consider neoadjuvant chemotherapy if you want to downstage, if you're waiting for other results like genetics, but they're sitting a bit on the fence. Not like, for example, the German guidelines are more like straightforward. Yeah, you should go for surgery first option. But I would like to try to start with the systemic treatments for most of those ladies, but that's always a discussion in the MDT, and we are not always successful in that discussion. I see Bahadir had his hand up.
I will send you the Swedish guidelines.
Yes.
I think we have Bahadir here with us, and he wants to come into the conversation with a question.
Bahadir.
Hi, everybody. I would like to ask, because everybody is discussing about this BRCA1 or 2 gene mutation pathogenic variants, I understand that everybody is very keen on testing these patients because she's 44 years old with no family history. So I understand that if this test turns out to be positive for the pathogenic variant, you will forego for a bilateral bilateral mastectomy, one therapeutic, the other one is a risk-reducing mastectomy. Is that correct? Everybody is agreeing on this? I mean, if this patient would have a positive pathogenic variant, let's say in BRCA1 mutation, and then you would choose to go with the bilateral mastectomy?
So there's two things here, Bahadir. I think the first thing is that if she had an awful disease that's heavily node positive, no, we'll still conserve and see how she does, or we will not do bilateral because the other breast might not be part of the equation on the short term, might be on the long term. But it will guide our treatments in terms of oncological treatments if we have the BRCA1 for the systemic treatments. And yes, if this lady responds well, especially to her chemotherapy and her whatever other treatments we give her, then it is an option to discuss bilateral mastectomies, risk reduction at the same time on the go. But if she was somebody with a 5-centimeter tumor that's node positive, then you might need to start thinking twice before offering her bilateral mastectomies, as that might affect her further systemic treatments. But I don't know what the others feel about that.
Is there any evidence to do this kind of bilateral mastectomy even in these patients? I mean, that's the question here, because when you start making a conversation with your patients, the patient will follow you, and this is very dangerous. That's why I'm telling this. I'm just trying to point out this point.
Bahadir is usually making an excellent point. The big catch in this discussion is that the presence of a BRCA mutation, regardless of age, but especially BRCA1, suggests that her next cancer, if she gets it, is going to be 3 times more probable to be ER negative and in need of chemotherapy or a luminal B-like. So what most patients are concerned about when you discuss it, because what I usually tell them is that your survival will depend from the index tumor. This is something that has been clearly demonstrated, and so on and so on. But at the same time, I see that a motivational factor for them is to not undergo chemotherapy again in the future if that can be avoided, or a new cancer and so on.
So exactly what you say is so the contralateral breast will have a much higher chance of getting another cancer, even more than 10 up to 20 years. There's a couple of studies, one that showed increased incidence in the first 10 years, and one showed even higher incidence between year 10 and year 20. Survival benefit is questionable. Some papers will suggest that there might be a benefit. Some papers will not suggest that there's a benefit. It really depends on the index tumor, because if the index tumor is an awful tumor that's heavily node positive, then that dictates the survival more than the contralateral mastectomy. But it's not only about that, it's about survivorship. So the worst part of the treatment is not usually the surgery, it's not usually the radiotherapy, it's usually the chemotherapy, and most people will not want to go through this again. So there's lots of different parts of that discussion. It's not only about the actual cancer, it's also the gene will come into the equation in 2 to 3 years time. I don't know, somebody also had their hand up before. Or shall we go ahead with the second
I
patient?
think we should carry on because we are learning
Okay.
a lot. We can be talking forever for these things.
Of
Shall we
course.
carry on there?
So the second lady is a 33-year-old lady, which is presented with a 1 centimeter lump. It's a big mass, not that discrete. She's a D-cup breast. The lump has been there for a couple of months. It is increasing. She's fit and healthy, but her BMI is 42, and that's a key number here. She had no mammogram done initially as she presented under the age of 40, and the ultrasound scan showed a 12 millimeter lump, and the axilla showed a node of 15 millimeter with cortical thickness of 4 millimeters, which is abnormal. And the biopsy was done that showed a grade 3 invasive ductal carcinoma, fully differentiated, and it's ER 3 out of 8, PR 0 out of 8, and HER2 negative. So we treat the 3 out of 8 as a triple negative. We can talk about that if you want us. So what do we need to do first, imaging wise?
You read the options. So the options are mammogram, MRI, or mammogram and MRI.
Yes. Oh, I started the next question. See, I'm clicking too many things. Let's see the result of the first question first. That's great. So it's great to see that most people will do both. And the second question is in terms of the axillary node. What will you do for the node? And we're not going to spend lots of time on the node because we had lots of scenarios on target dissection. So will you do an FNAC and put a mark in placement? Will you do a core biopsy and put a mark in the node? Or will you do either FNAC or a core biopsy, but you don't always mark the node?
Yeah.
Stop pressing buttons.
I cannot. So shall we have the result for this? So most people will do the core biopsy and put a marking placement, which is great. Now, we need to remember that this is a young lady. She has no family, no children. So not no family, no children. So fertility is always an issue. Genetics is always something that we need to address, and anybody that fits the criteria, we always do the test on once we have the biopsy results. Any comments from the panelists?
Now, there's a comment because we discussed earlier on about the core biopsy on the lymph node. In this case, that we don't have a HER2 low, we have a 0 HER2. Is there any point of checking the immunohistology of the lymph node? Or are we happy with an FNA here? I mean, it's going to hardly change anything, isn't it?
So for us, what we do is we do an ultrasound scan and we do the biopsy in the clinic, and they do cytology in the clinic, and the cytology is read in the clinic. And if the cytology does confirm malignancy, we don't always do a core biopsy.
No. Earlier on, we talked about the initial tumor being HER2 low, and ER negative, PR negative, and HER2 low. And we said that we would like to see the immunohistochemistry on the lymph node because that may be HER2 positive and change the plan. But in case we have HER2 0, is there any point of doing of checking the lymph node? This is my question. I don't know if it's clear what I'm asking.
Yeah, so it's clear.
Okay.
In this case, I personally do not feel that we would benefit from the core biopsy, and we have to consider the radiologists that will be fighting with an axilla in a patient with 42 BMI, the challenges with that, and the risks with that, and things like that. So I think we just need to confirm the presence of metastasis over there and just live with it. So I can understand that in terms of pragmatism, FNA would be sufficient.
Okay, that was to clear up things because it will not probably offer anything to know what is the status of the immunohistochemistry status of the lymph node in this case. Andreas?
No, it's not. I mean, we're not expecting any surprises here.
Okay, Yazan.
We would, as I said, we would just do only cytology. We would not do a biopsy if the cytology gives us the answer. But I think somebody was, sorry, because I'm not on the main screen, I cannot see everybody clearly. There was somebody with a hand up.
I think it's Yanis.
Oh, Yanis.
Yes. About the necessity for a core biopsy. even with different phenotypes between primary tumor and the invaded axilla, we don't have data to change our practice to make a decision about treatment. Is there any data that supports that if we have different phenotype, for example, a HER2 positive axilla and a HER2 negative primary tumor, we can give neoadjuvant with HER2 and the HER2 factors? Is there any evidence, any data for this?
I don't think there's any data for this, but if the phenotype is different, you need to start looking in the breast. Have we missed anything?
Exactly. This is the evidence is that you misclassify. So a single core biopsy with 2 or 3 passes can give you a false negative of 6%. So if you have differentiation, and especially in cases that are also borderline, so the 2+ in the HER2 amplification that comes back as negative, you may have struck a lower enriched area. So you have to go back for that if the node suggests that it is positive. Because you cannot get a false positive HER2 result, but you can get a false negative.
So let's move on. So this is T1N1, no mets, most appropriate next step. Will you give neoadjuvant chemotherapy with or without immunotherapy? Will you give, we'll go for upfront surgery. So what will you choose?
If we don't have concordance in this question, then we must start from the beginning.
Shall we go back to 9 o'clock in the morning?
I think so.
Shall we see the results then?
I wish there was somebody here to answer why without pembrolizumab. There's some people that do not believe that immunotherapy. I mean, I don't think anybody from the panel voted for that.
And
Voting
also-
is secret. We cannot disclose that.
Okay.
My
let's
question
ask-
would be, did you give platinum as well?
Yes,
Because
it-
triple negative, is it a triple negative or not?
It's
yeah,
a
it-
triple
you,
negative,
you,
yeah.
you would treat this lady like a triple negative breast cancer. So you would, what we technically do is start with carboplatin, paclitaxel, pembrolizumab, and then switch to anthracyclines whilst we continue the pembrolizumab. So we would treat her as a triple negative.
And that's what we've treated her. And she started her chemotherapy. We got the BRCA test back, and she's the BRCA1 positive. She had neoadjuvant chemotherapy, and she had complete response in the breast and the axilla radiologically. So everything has normalized. There is no tumor seen on mammogram, ultrasound scan, or MRI scan. And now it's surgery time. The problem for this lady is that this is a lady that was treated on one of the islands, because we see also patients that come from the islands. So we did not realize that she's been treated until she was referred to us to surgery, because there's a local surgeon that usually keep an eye and babysit the patients until we know if they can be done locally, if the tumor is palpable, or they need to come to us if they need TADs and things like that. So we knew a bit late, but now it's surgery time. So what is the best option for this lady? So she has a small tumor that is T1C, but it's not positive, triple negative, complete radiological response. Will you do a breast conserving surgery? Will you go for bilateral mastectomies with no reconstruction? Will you do a unilateral mastectomy with no reconstruction? And will you do a unilateral mastectomy with reconstruction, or bilateral mastectomy with reconstruction? So we're not discussing the axilla because we're doing a TAD for her.
How old was she?
She's only in her 30s, 33, I think.
The same patient.
Yeah, she's the 33-year-old. And remember, her BMI was 42.
So do we see the results now?
That's not what we have done, because her BMI is 42. Trying to put her through bilateral mastectomies and implants, there's a high chance this will fall apart. Trying to put her through mastectomies and DIEPs, that will not work. Doing unilateral mastectomy will be an option, but though she's healthy and fit, the BMI 42 is a recipe for disaster. We discussed with her mastectomies, we discussed with her reconstruction, but higher risk. The problem, if you want to put an implant, most likely this is a 30-year-old with a high-grade tumor, triple negative, node positive, they'll irradiate the chest wall. So putting the implants might cause problems. The discussion was with her was along the lines, breast conservation is safe on the short term, but you'll need the mastectomies on the longer term if all is okay. Mastectomy and reconstruction is an option, but most likely it will fall apart because of the BMI. The better option will be if we conserve the breast now, do a target dissection, finish all your treatments with less risky surgery, and then we'll see in 2 or 3 years' time if everything is okay. And if you manage to lose some weight, then that will open more options for our mastectomies and reconstruction. I don't know if everybody agrees with that or they feel that they would have done anything differently. Any comments from the panel?
I have a comment.
Everybody.
Oh, you
Yazan,
have lots of hands up. So we'll start with Bahadir first.
yes.
Thank you very much. I would do the same thing. I mean, because, you know, this is a young lady and we don't know the response to the chemotherapy, to the systemic treatment, whether it is a complete response or not, because the chance of, you know, dying because of the disease is not so low in this case if there's no complete response. What I would do in these patients is just not because the BMI is high and the mighty complications for the reconstruction is high, but I would wait at least 2 years after doing the breast conserving surgery, because this is the period that you couldn't have the highest, you know, chance of dying because of cancer or the relapse, not also only dying. So in these cases, what we are doing for the time being, especially in young patients with the BRCA positive patients and also a triple negative cancer patients, we would wait at least 2 years to see what the disease can go through. Then we can decide about whether to do a bilateral mastectomy with the risk reduction on the contralateral side. And also, meantime, you can have the weight reduction and so on and other supportive measures to make the surgery in meantime more safer.
And I've started referring some of those ladies with a very high BMI for bariatric surgery because it makes a big difference to them. But that's not based on any evidence or anything like that. But if somebody loses significant weight, then the risk reduction and reconstruction is better. Let's go to Konstantin.
Yeah, hi, Yazan. So I would offer her both options, like breast conserving surgery versus the bilateral mastectomy. I do completely understand the risks from doing a reconstruction of this patient. It's a difficult situation because now you've done a wide local excision, so you have radiotherapy. So the only option, if she wants to have reconstruction, would be to do a DIEP flap later on, as you said. But with that BMI, she wouldn't fit the criteria, I think, for a DIEP. They wouldn't, the plastic surgeons wouldn't accept her. So this is something that I think should be discussed with the patient, and you know, a joint decision should be made. But she should be aware that unless she loses weight, she won't be able to have a DIEP flap. I don't know if you agree with this.
I think Dr. Maragoudakis has to say something.
Yes, I wouldn't be very happy to irradiate a patient on her flap or the tissue expander or to the permanent implant. And I wish she could avoid reconstruction at the moment so that she would have unilateral mastectomy, secure all the oncologic treatments, and see a delayed reconstruction.
Michalis?
I managed to disagree with everyone. Yeah, I want to be a devil's advocate here. I do not want to do a mastectomy and reconstruction on an irradiated breast, even 2 years down the line. If now the risks are high, then the risk will be equally high or even higher, I think. We have the privilege here in Athens to operate on a lot of, on many obese patients and smokers. We know how it is. And I think that chances are higher to have a failure, reconstruction failure, but I think it is a valid and, in my opinion, the best option to offer here reconstruction, immediate reconstruction, with an expander perhaps, but an immediate reconstruction. I avoided for bilateral mastectomy reconstruction.
And Andreas.
So if we are discussing the bilateral mastectomy thing, and you've got an obese patient that needs a safest option, I was just wondering how everybody would feel with bilateral Goldilocks mastectomies, because it's a low-risk procedure. You will have tissue that will avoid her from being completely flat. You can deal with it much easier in the reconstructive setting with regard and evaluate radiation injuries and things like that. I would feel that in this setting, Goldilocks would be much more appropriate. And in terms of radiotherapy, the radiation oncologists here are much happier if you do not make them irradiate a massive breast with a broad base that when she lies on the radiation suite, the nipple is behind the ear and so on.
So the Goldilocks is a great option, Andreas, but the Goldilocks is for big breasts, not for big ladies. And many ladies are high BMI, but the cup C cup. So when you do a mastectomy, if you put the Goldilocks, she'll be flat.
Yeah, but still, even if she's a double E, she
will. No, she wasn't. She wasn't somebody.
But my point here is that you are not making something that will work cosmetically. This is not a definite option. It is just a bridging that will allow for doing the mastectomy, sparing some skin, and let you evaluate the situation depending on how the radiation therapy has affected her or not. That's the only case I am making.
It's an option. Anybody else have their hands raised, or should we go to the...
No, may I say something?
Yeah, of course.
You know, when we're having these discussions, we're forgetting something. You're very experienced surgeons and you're discussing an issue from the top level. But the audience now are the lay surgeons, and whatever you're suggesting may not be their capability. That's why we should we should recommend the simplest method for them to make the minimal, damage to their patients. So this is a patient with a high BMI. I had a patient 15 years ago, only my mortality, had a Pickwick syndrome after mastectomy without any reconstruction, and she died in 1 month in ICU. So here in these patients, when recommending something, we should think of all these things, because these are, of course, these are the scenarios that we're thinking about. We're trying to find a way to solve the problem. But that is why we should be a little bit, in a low level to, say our, thoughts about these patients. That's why I suggested to go on with the minimal, a surgery like breast conserving surgery with a, mammoplasty, with a, reduction mammoplasty, either with a bilateral, you can do that. But then afterwards, because still you don't have any evidence that the contralateral risk reducing surgery is reducing the mortality in these patients. So that is why I still resist on saying that maybe in the first stage we should do a minimum surgery, just remove the tumor and do whatever you can do and accelerate, then wait for a while, and afterwards maybe we can think about the contralateral surgery in these patients.
And that's exactly what we've done to her. So the POSH study did not show any difference in survival in the short term, in 2 to 3 years' time. And that's what we've exactly done with her. We discussed mastectomies, higher risk reconstruction. We discussed breast conservation. And that's what we've done, is we've conserved the breast. We've done a target dissection. After the neoadjuvant chemotherapy, she had residual disease in the breast, only a small 2 millimeter invasive cancer, and she had response in the axilla. So the axilla had previously involved nodes that have normalized now. And the question is, what's the next step? Systemic treatments. Is it immunotherapy, capecitabine, no further treatment, combination of a few things? Shall we get a vote first?
Let's have the voting box, please. Voting box, thank you.
Some of the questions are repeated, but this is the point to get and pass some messages. So we had a previous case that it was almost a similar question, but I'm quite sure that if we see the answers now, it's going to be completely splitted. Let's see. Oh, we managed to do something here. 76%. Okay.
So
Okay,
then we'll move
Vasily.
ahead. So shall we move then? Because this is a repeated question, or do you want to take any questions?
I think any short comment from Vasilis, I think, about the combination of Pembro and capecitabine.
I think I didn't vote for this because I would go for option 5, which would be olaparib. This lady is BRCA positive.
Yeah.
And based on the Olympia study, she would qualify to receive olaparib, which is the only adjuvant treatment so far that has demonstrated overall survival benefit.
Indeed.
So for patients that would fit the criteria, we would actually offer them olaparib rather than capecitabine. The question is whether you would try to combine this with pembrolizumab. I wouldn't. There is some good safety data for use of combination of anti-PD-L1 with PARP inhibitors in other tumor types, but in essence, we're not in the field that we could potentially feel more satisfied having had phase 2 studies in metastatic cancer, such as the Pembro and Cape combination. So I think for these patients, I would actually offer her a PARP inhibitor, an olaparib, and not pembrolizumab or Cape.
That's great, because
Vasilis,
I think she was treated.
If this patient was not BRCA positive, are you happy with the combination of capecitabine and pembrolizumab?
Yes, the reality is that in the UK we're restricted to that, where we may not necessarily be able to do this, but I think we have good data to support the combination from metastatic breast cancer. I think we have to be very careful though. This regime, the Keynote 522 regime, is not as easy as we would like. As we have seen in the study, I think the real world representation of toxicities is slightly different, I think. So I think we have to be careful. If it's a patient that has a high risk of recurrence, then you would combine it, but you have to monitor them very closely. If a patient is quite low risk, if there's the RCB is class 1 and there's some concerns, then I think you would probably choose one of the two agents.
And so this study was treated about 3 years ago. So Olympia was not published at that stage. That's why I had not put it as an option, but it's a great option. Thank you for that. I will go only briefly through this last lady because I'm already 40 minutes into my 45 minutes. This is a 65-year-old female patient admitted with the exacerbation of COPD, third admission this year, had a history of ischemic heart disease, had a few myocardial infarctions in a few years before, now has an element of heart failure. So she's a Davidson textbook of medicine. She cannot walk more than 50 meters before getting short of breath. She cannot lie flat for more than a few minutes. And when she had the biopsy, she was sitting head up 45 degrees to manage to be able to have that biopsy. And during her admission, a CT scan showed something in the breast. And that's how we found out that she has this little tumor. So this CT scan, she has serious CT scans, and this CT scan showed this tumor lesion is quite new. So she came to clinic. She had a M5 lesion, U5, 16 millimeter, and negative axilla. And the biopsy, of course, showed a triple negative cancer, as they always do. So it's an adenoid cystic carcinoma. What treatment options will you consider for this lady? Will you do this local excision under local anesthetic? Will you offer radiological excision? Will you do a mastectomy and sentinel node biopsy? Will you give them any primary endocrine? Or will you consider mainly the excisions, which is the option 1 and 2? And if we take a few seconds to vote and then see the vote result. Shall we see the vote result? That's good. So most people will do a wide local excision under local anesthesia. My issue with this lady is that she cannot lie flat. So trying to lie her flat to do a wide local excision under local anesthesia will be very challenging. And I don't know what we've done is in a small cohort of patients that are not fit for a haircut. We would just arrange for them to have radiological excision, and we're collecting our data because it's better than doing nothing. We know it from the NAPCOP, which is a UK-based or English-based study or audit looking at treatment for patients with breast cancer above the age of 70. This is not the case here, but patients are not fit, even sometimes with triple negatives, they do nothing. But if you have if you manage to biopsy them and the lesion is not big, why not try to hoover it out? And we had few patients that we have managed to hoover the lesions out, and we had a reasonable good local control. Any comments from anybody from
Can I ask what is the expression of Ki67 in this patient? Do you have any report for that?
We don't do them routinely, Bahadi.
Okay.
We're very rare to do Ki67.
Probably it is less than 5%. I mean, I can say that in these patients, she's 65 years old and a very serious comorbidity. The life expectancy is even less than 5 years, maybe less than 10 years. So in these cases, starting for a primary endocrine treatment would be the most suitable option, and see what happens in time. If it goes well, you can continue with it up to 5 years. And anytime, if you have any problem, you can do a radiological excision or a wide local excision at that time. That's my idea on this patient.
Bahadir, is it triple negative though?
Triple negative. She had adenosine.
No, this is triple negative. No, this is not triple. Yes, of course, endocrine treatment. Yeah, you're right. Okay, I'm taking my word. Right, okay.
This is adenosine carcinoma, which is more a well-differentiated type of triple negatives that behave differently.
Have an excellent behavior. She will not die from that.
She will not die from that. You know, all the cohorts about this tumor, it says that there's no death because of this tumor. It is a little bit more than, fibroadenoma. It's like, ADH or LCIS. So here in these cases, I mean, if you can do, because she cannot lie flat, that's the problem. So what you can do, she can, sit in an upright position and make a vacuum biopsy, maybe, if you wouldn't do anything, if you wouldn't give anything to this patient, and by means of chemo, therapy. I mean, it's not a chemotherapy. I mean, the actual chemotherapy, but you can't give any hormonal treatment and anything else. So what else is left? It's the only excision in these patients, or you may follow the patient, whether the tumor is increasing or not in size.
So because if the patient manages a core biopsy, most of the time they'll be able to manage a large volume excision. It's not that much different from the radiologist point of view. So we got about the radiologist. Michalis, you have your hand up for a while now.
Well, desperate times call for desperate measures. I've heard of, I don't know if you have heard about cryoablation or transcutaneous RFA. Not every patient can have it, and not every area in the breast can have it. But if this type of cancer was a bit more aggressive of a cancer, I would seriously think about cryoablating it or burning it with an RFA needle or microwave it or something like that.
The problem with that, Mihalis, is most hospitals, we don't have cryoablation, we don't have radiofrequency ablation, but most centers that are screening centers will have a large volume vacuum, and you can excise it with a vacuum. It's not that much different.
I think I thought she needed to lay flat for the vacuuming.
No, not always.
think-
There are some devices
No.
that you can sit patients upright and can do that.
They do the vacuum with the mammogram, and they cannot lie flat with a mammogram. So
Yazan, I think you should move on. Shall we?
yeah, I think I'm not going to do the fourth case because I'm already on my 45 minutes, Sophocles. So we'll just stop here. Otherwise, we'll make the overrun a bit longer. Anybody wants to do any final comments?
I think we're fine. Let's
We're
move
I
on.
think
fine,
we'll
yes,
handle
good.
that.
We'll do some comments in the end, I guess. Michalis.
That's good.
Yes, so we're going to say a few comments at the end, Yazan. You're right. If we keep on talking about these cases, we will never stop. It's borderline cases. We know that. And now I have the great pleasure of introducing someone who we already know very well. We have the honor to have Dr. Bahadir Güloglu with us, and he kindly accepted our invitation, and he is going to present to us cases, interesting borderline cases of HER2 positive cancers. Bahadir, I introduced you before, but you hadn't connected. So let me say it again. Bahadir is many things, but here he is as the lead of Breastix 24 Hours. And this webinar today, which is of course initiated by the Hellenic Society of Breast Surgeons, is done in collaboration with Breastix 24 Hours. And this collaboration gave birth to this international webinar. So thank you, Bahadir, for that.
Thank you very
And
much.
the floor is yours.
Thank you very much for the kind introduction. I'm a little bit late. Sorry for this, my late presentation here, because I was online at another meeting. Even it's in Athens as well. It's a Manusmedi meeting now going on in another hospital in Athens. But, you know, fortunately, I can join both meetings in the morning in that meeting, in the afternoon in your meeting. I'm so much privileged to be with you here. So I assume that I have half an hour to present some cases, some borderline cases, in order to open some roads to the solutions to those cases, because we almost always talk about in classical teaching the straightforward cases, and most of the time we have some answers to them. But here, the cases that I will show will not have one correct answer. So that's why it is very important to hear the opinions from various people from various parts of the world in order to discuss on them. So I'm now trying to share my screen. If you can see it, please confirm that you're seeing.
We're okay, yes.
It's okay. All right. All right. Yeah. So I have many cases, but according to the time, I will stop at when my moderators say that it is enough. But until that time, I'll try to give as much as I can do. So the first case is a 52-year-old female patient, postmenopausal. She has 2 centimeter mass. That's the primary end, and 8 millimeters. And second tumor in the right breast, and in the mammography and ultrasound, it seems is a Bayer, it's 5, and ultrasound axilla is normal. There's no family history, no associated diseases, and the core biopsy revealed that she has an invasive cancer. The biopsy only done to the big tumor, and it's grade 2 ER, no expression in ER and PR, and HER2 is 3 positive in this patient, and Ki-67 is 32%. And the systemic evaluation revealed no systemic metastasis. So on this ground, I would like to ask the audience, what would your preference to start the treatment for this patient? So would it be a neoadjuvant systemic treatment? This is a 21 millimeter, clinically 21 millimeter by ultrasound and mammography. and there's no axillary lymph node involvement, it seems, and or would you like to start with an upfront surgery like, you know, local excision and sentinel lymph node biopsy? Please, you may vote in 10 seconds. Okay, we may see the results if it is possible. Yeah, and I can see that nearly 75% of the audience answered as the neoadjuvant systemic treatment. That means that you will start with a standard anti-HER2 treatment plus AC and IC plus taxane. So I would like to ask the opinion of my panelists, whether is there anybody who would choose to go with an upfront surgery here in this case? Anybody?
I could be the devil's advocate, being actually the medical oncologist. Who would you expect?
Yeah, please. I would like to hear this. I mean, all right.
This is one of the cases that can be discussed in the MDM, and I think the reality for this patient is that she could actually go for upfront surgery because she fulfilled the criteria for the APT study that recently provided an update of 7 years follow-up that has shown excellent survival outcomes. I think there are certain things we have to consider, and I think the reality is that if there's other factors that you need to consider neoadjuvant chemotherapy, you should, and that would be in the case that you think you could convert someone's surgery, that the tumor is in a rather odd position, that the surgeon would benefit from use of neoadjuvant chemotherapy, or are there any other significant risk factors that you're concerned about the patient? The important thing, though, is that in essence, this patient would receive quite a lot of medication. So they would receive an anthracycline regime, they would receive Taxol, they would receive you could argue they borderline could receive dual anti-HER2 therapy. But in reality, we know, and now there's a drive mostly in the US to avoid anthracyclines in these patients, as they don't necessarily always demonstrate the same result with regards to pathological complete response if you add them. The difficulty with these patients is that if they don't have neoadjuvant chemotherapy, then they miss out the possibility of assessing their response, the assessment to understand the biology of the cancer and the use of adjuvant therapy such as Kadcyla. But I think this lady could fulfill the criteria for APT and go ahead and actually have less chemotherapy than needed. So because she would receive paclitaxel herself in the adjuvant setting, and the results from the recent update are quite reassuring.
Thank you, Angelis. That was one of the answers that I was expecting from you, although you're a medical oncologist, but I would like to hear also the opinions from the surgeons. Is there anybody volunteering to make a comment on this? Would you prefer to? Yeah.
Yeah, in terms of the APT study, I think it was mostly for the HR positive lymph node negative tumors that we had all these excellent results. And I think for those HR negative tumors, I think the benefit is higher. I think they mostly go with Catherine and less with APT. So Vasilis, what do you think about that? We're talking about an HR negative tumor here, not an HR positive, HER2 positive tumor.
I mean, usually HR positive, so triple positive breast cancers tend to have a less response with regards to PCR than that ER negative HER2 positive. So I think in this case, I would probably favor her having adjuvant treatment.
Yeah.
So may I just, because this is always, we always discuss in the MDT, and they always talk about Hellenic paper and the APT studies. And I know that some of my colleagues think that I'm a dinosaur, but sometimes we go ahead with the surgery first rather than chemotherapy first. Remember, this is not a T1C, this is T2, but if we argue this is a T1C, for example, the evidence is
limited.
Not every T1C is T1C. There's grade 2s, there's grade 3s, there's ER negative, there's ER positive. So you need to tailor all that to the patient. And the other thing is sometimes, and correct me if I'm wrong, if it's a T1C, when you start with your chemotherapy and the adjuvant and then the neoadjuvant setting, you might de-escalate that according to the APT or the Hellenic study, and you might give a T1C chemotherapy with only Herceptin, not necessarily giving dual blockade. While if you do surgery up front and you find that the disease is a bit different, then that might change your chemotherapy. So potentially you might under treat with the systemic treatments. Am I correct in saying that or not?
And so I think the bulk of the population, the APT study did have the same type of size, so they were about 2 centimeters. I'd be careful if a patient had 3. They were included in the study, but they were very small percent. So for these patients, we wouldn't go down that route. But I think in reality, because in order to access Kadcyla in the adjuvant setting, at least in the UK, you need to have the whole shebang of basically anthracycline and Taxol and anti-HER2, which you could argue and say in that case that's overtreatment. But that's why we always have these discussions. And I think if somebody had a grade 3 cancer and there was other concerns about the risks, you would favor neoadjuvant treatment.
Okay, let's move on then to the second case.
Before moving on.
Yes, Andreas, please.
Yes, before moving on, just to make a point so that we keep the discussion on a realistic level. The APT is a phase 2 single-arm study that included only 8.9% of its patients that were more than 2 centimeters. So if we are concerned about overtreating by means of giving neoadjuvant chemotherapy, it is more evidence-based to go to an adept approach and going for single blockade with paclitaxel only, consciously sinking the expected pathological complete response to 35 to 40% than the 55 or 60% that it is in current trials, than discussing more surgery based on a phase 2 study. Again, in terms of what we need to stratify as level of evidence.
Okay, good point, Andreas. Thank you very much. So let's move on to the second case. Here. The second case is a 38-year-old female patient. She's premenopausal. She had 1.2 centimeters, a lesion at the inner out lower quadrant in the left breast. Axilla is normal, again, an ultrasound. There are 2 aunts with breast cancer, ages of 44 and 45. There's no associated diseases with the patient. The core biopsy revealed invasive cancer, grade 3, ER 10%, PR 0, HER2 3 positive, KI 67, 40%. There's no systemic metastasis, and the patient underwent a bilateral nipple areolas complex pair mastectomy, immediate implant reconstruction, and the left side. The left sentinel lymph node biopsy with the dual agent, and no frozen section assessment was done for the sentinel lymph nodes. And the permanent pathology revealed that on the left side, there's 15 millimeters invasive cancer, grade 3, again hormone positive, HER2 positive, and there are 5 sentinel nodes retrieved during the operation, and 3 of them had an involvement. The front is 4 millimeters. 2 others are macro metastasis. And the right breast, the pathology revealed there's a multicentric ADH. Now, the question here is, what is the next best step for the axilla management here? Because you now have 5 nodes retrieved, and 3 of them are positive, and 2 of them are macro, 1 of them is macro, and that is 4 millimeters. And please think that this patient will receive a chest wall radiotherapy in this case. So what would your choice in this patient? No further treatment, or level 1 and 2 axillary clearance, going back to the operating room, and level 1, 2 axillary clearance and the regional node irradiation, including the level 3 supra and internal mammary nodes, or only radiotherapy without any surgery to the level 1 and 2, or the radiotherapy to only level 3 supra internal mammary nodes, or radiotherapy to the all regional nodes, including level 1 and 2. So you have 10 seconds to give your answer to this question, and then let's make the discussion over it. So let's see the results now. Yeah, most of the people said that we can get the patient back to the operating room and make an axillary clearance plus in addition to the transport radiation, also the patient will receive a regional node radiation, skipping only level 1 and 2. So any opinion on this from the panelists? Nobody is raising their hands. Yes, Mihalis, please, and then Yazan.
I think that even Andreas Karakatsanis, who is looking for an excuse to avoid axillary clearance, will have to perform one.
No. This is very clear, evidence-wise. So what you need to do evidence-wise, you've got data post mastectomy radiotherapy in node-positive patients. You have somebody falling out of the criteria of the escalation trials. So whether we benefit or not, this we do not know. But what we need to do is very clear here.
I would be equally interesting to see what if Dr. Maragoudakis is here. I'd like to see. I would be very interested to see the fields of radiotherapy.
Well, since we will do level 1 and 2 axillary clearance, and we have, what's the answer? And if we don't have any other lymph nodes involved, then we can irradiate axillary level 3. But I will be very cautious to irradiate the internal mammary nodes and the supraclavicular because of the additive effect of side effects of radiotherapy and surgery.
Would you irradiate the internal mammary nodes?
Not very often, actually. I have to find many lymph nodes involved in the axilla, and the prognosis of the cancer to be very bad. I don't like the idea of irradiating the internal mammary chain because increasing the toxicity to the heart and the lung as well.
Okay, thank you, Yazan.
I think we just need to treat the axilla. But will surgery make a big difference than compared to radiotherapy if radiologically this was all small nodes? Because many people will just irradiate rather than go back and clear. What's your thoughts?
Yes, I'm also curious about hearing the opinion from other panelists. Sophocles, what would you do?
Yes, everybody. Yeah, I voted for clearance, of course, and then for regional radiotherapy to the supraclavicular, intraclavicular lymph nodes and internal mammary, because this is what guidelines say. And most of the times I stick with the guidelines. So I don't know. I voted for 3, to be honest.
So what happens if the patient would refuse to go back to the operating room?
Well, the patient can refuse any treatment at all, so she will have radiotherapy, I guess.
So I would like to ask Evangelos, in this case, would he be comfortable to radiate to level 1 and 2?
In case we don't have the sample of level 1 or 2, then we radiate all the regions of the lymph node.
Exactly.
We have information.
In order to have the local control, that's why I'm asking you, for the level 1 and 2, because that's the positive area, 3 out of 5. Okay, so let's move on to the other scenario then. So this is the case 3. This is a 44-year-old premenopausal woman, and it's a screen-detected cancer, no family history, no associated disease. There are 3 mass-forming foci. Largest is 1 centimeter, 2 separate quadrants, and there's a disseminated microcalcification area, composed of 5 centimeters. Axilla is clinically and radiologically negative, and core biopsy to the largest tumor revealed that is an invasive cancer grade 3 ER, 20% PR negative, HER2 3 positive, Ki67 55%, and PET CT says that primary tumors with submax 7.2, no uptake in axilla and other distant sites. The patient underwent unilateral skin sparing mastectomy with immediate implant-based reconstruction with a direct-to-implant and sentinel lymph node biopsy. And the pathology at the end came as invasive cancer, grade 3, size 15, 8, and 7 millimeter, 3 foci, ER 25%, PR 5%, HER2 3 positive, KI 67, 50%, and 3 sentinel nodes. There are no metastases in it, but the margin is focally positive at the anterior margin and the flap side. So what would be your strategy in this patient to control the disease in the breast? Observation with no further surgery or radiotherapy, no further surgery, nothing, no surgery, no radiotherapy, no further surgery, but chest wall radiotherapy only, no further surgery, but boost radiotherapy, the involved skin only, no further surgery, chest wall radiotherapy, and boost radiotherapy to the involved skin, removing the implant, complete skin flap resection, and leave it as a flat chest mastectomy, or partial skin flap resection plus repairing with an expander, and partial skin flap resection plus repair again with an implant, DTI reconstruction. Can we have the questions on screen to make the audience to vote on it? You have 10 seconds to do it. Yes, we have 7 choices. Let's give 15 seconds for this. It's a little bit difficult to read all those choices. As a focally positive margin, it's not a frankly involved margin on the anterior side. This is not lateral, this is not posterior, this is not medial, not superior. This is the anterior one. Okay, we may see the results. Choice 4 is a 30% said that no further surgery, chest wall radiotherapy, and boost radiotherapy to the involved skin. Now, I know this is a difficult situation, and we don't want to confront a scenario like this, but you know, 1 or 2 times in a life, maybe it can come to your, reality. So I would like to ask, yes, Evangelos, let's start with you. You're the radiation oncologist. What is your opinion on this patient? Maybe you can make the life of surgeons more easier.
We all wish not to have a situation like this. We all know that if we operate that lady, there is a very small possibility to find residual disease. On the other hand, I'm not willing of irradiating after skin, after expansion, after reconstruction surgery. So what I would recommend is to irradiate only to the involved skin with no further surgery. I wouldn't like to have extended fields to the remaining chest wall, because that will be very toxic for the reconstruction. So I would focus only where there is the greatest possibility of a recurrence.
Thank you so much. So Yanis, you raise your hand.
I'll go more far than Dr. Moragoudakis. It's focal invaded margin, and is as I understand, the anterior margin. The possibility to find residual disease with a new operation is minimum.
Yeah.
And furthermore, it's a HER2 positive disease. Systemic treatment in adjuvant setting has not only systemic effect, but furthermore local effect. So I voted observation with no further surgery or radiotherapy.
Okay, thank you very much. Any more comments from the panelists?
I think we should move on.
Okay, let's move on to our next case. I'm just trying to, yes, this is case 4. Is a 52 years old postmenopausal woman. The radiology says that she has a 30 millimeter isolated as a one tumor, a solitary tumor, node negative, and there's no metastasis. It's a hormone positive, HER2 positive tumor. She received the classical neoadjuvant systemic treatment with the dual anti-HER2 treatment plus AC plus T for 6 months. And at the end, after evaluation of by MRI, ultrasound, and clinically in mammographically clinical complete response, and the patient had a wide local excision with the sentinel lymph node biopsy with dual agent. And during the operation, only one sentinel node was retrieved, and it was found to be tumor negative during the frozen section in the operating room. And the final pathology revealed that there's a residual disease with the 3 millimeters, again with the same biology, and the margins are clear. And at the end, again, that sentinel node turned out to be negative again, like it was found in the frozen section. So at the end, you have only one sentinel node after neoadjuvant negative. So what would be your strategy in this case? I mean, is it enough for you to stop with the one sentinel node, which is negative in this patient, the one patient with HER2 positive, HER2 positive, and with a remaining tumor in the breast? Observation, level 1, 2 axillary clearance, or only radiotherapy to level 1 and 2 only? And your answer is for 10 seconds. And the patient will receive, of course, radiotherapy to the whole breast. Yes, now we can see the results. Yeah, observation, 65% of the audience said that observation would be enough. So any comment on this? I don't want to spend too much on time with this question. Any comment against this? Is there anybody who would say that more control in the axilla, like axillary dissection or radiotherapy? Evangelos, it seems that you're raising your hand, but I think this is not for this question. It was for the, okay, thank you.
Now it's not, there is no reason to have axillary clearance because nothing has changed from the information we had. Since we have a negative lymph node, there is no reason to have extra operation. And of course, there is no need to irradiate since it is negative. The lymph node is negative.
Okay. If there's no more comments on this, I will move on to the next one. It's a case 6. This is a 43 years old. I think this will be the last one, I guess. There's a premenopausal woman. As clinically, there is a 43 centimeter tumor. It's a multicentric tumor. There's N2, M0, hormone negative, HER2 positive tumor. Largest tumors at the upper outer quadrant associated with inflammatory changes confined to the 1/3 of the breast. And she receives neoadjuvant systemic treatment with appropriate regimen. And clinical complete response was found both at breast and axilla. And there's no family history, and gene test says no pathological variant. So here in this case, after neoadjuvant systemic treatment, and remember that the patient had an inflammatory changes on the breast, whether you can count it as an inflammatory breast cancer or not, it depends on your judgment. What is the best choice for breast surgery? Because there's complete response to the systemic treatment. Skin sparing mastectomy with immediate DTI reconstruction, skin sparing mastectomy with 2-stage reconstruction, first expander radiotherapy, then implant, nipple areal complex sparing mastectomy, again with the DTI reconstruction or with 2-stage reconstruction, or would you prefer to do a standard mastectomy without reconstruction, flat chest? And let's have the choices on screen to vote. You have 10 seconds to give the answer.
You didn't have a choice of wide local excision.
Yeah, I didn't put it. Yes, well, at the end, maybe we may discuss about it. You're correct. I should have put that choice as well.
So obviously now we had a similar case last year, and
but
had this question about the definition of inflammatory breast cancer.
For the scenario, I put it as a multicentric tumor just to avoid that option.
Yes. Okay.
All right.
So it's the definition of inflammatory breast cancer here, isn't it? Is it, or if it's not? Well.
Well, it depends. I mean, that's why I'm asking this question to everyone. That's because there's not one straightforward, description for the inflammatory breast, because it could be a primary inflammatory breast cancer or it's a secondary inflammatory breast cancer. So the choice pipe is a standard mastectomy without reconstruction. So not most of the people, I mean, the half of the people says that there's no need to do a reconstruction or no need to do a skin sparing mastectomy in these cases. Any comment from the panelists against this? Who would do a skin sparing mastectomy? Yeah, Mihalis, please, starting from you, then Yanis, maybe. Yeah.
I apparently I'm the bravest one here. Because if we stick to what we teach to the students, and correct me if I'm wrong, this is not an inflammatory breast cancer, is it?
Yeah, yeah.
So it does not fall within the criteria of inflammatory because it's smaller than 1/3.
Yeah.
So it's not T4.
Yeah. It's T2 still, yes, but N2.
It's T2 and 2, so it will get radiotherapy.
Yeah.
So this is number one. I think it will get radiotherapy. I cannot see why I cannot keep the skin and do a reconstruction. Because of radiotherapy, I would use a 2-stage reconstruction.
Yeah.
But I voted for a mastectomy with reconstruction.
Thank you, Yanis.
With radiotherapy.
Yeah, of course. Yeah, Yanis.
Yes, I voted the option 2, skin sparing mastectomy with 2-stage reconstruction, because the only contraindication, as told Michalis, is irradiation, but this is a relative contraindication. So I think we can proceed with skin sparing mastectomy with 2-stage reconstruction.
Okay. Any more comments on this? I would like to move on to the second question with this case. So what would you do for the axilla in this patient? Again, remind you that in the beginning at the admission, she had N2 disease. So would you do a sentinel lymph node biopsy? Because after neoadjuvant systemic treatment, the response seems complete by radiology. Or would you do a level 1 or 2 axillary dissection in this case? You have 10 seconds to answer to this question as well. I think we may show the results. It's not a long question. Yeah, half. So I would like to ask the opinion if there's any panelists would prefer to do an axillary dissection in this case. Is there anybody among the panelists?
I would do axillary dissection in this case.
You would do an axillary dissection.
Yeah, no, I know there's no evidence for N2 that we can do all these fancy things we're doing now. So I'm quite skeptical of going and doing all this thing with something that looks like an inflammatory cancer. Maybe it is, maybe it's not, and has a bulky disease in the axilla from the beginning. Yeah. And then all of a sudden I decide that I'm not going to do anything. I'm just going to take 1 or 2 lymph nodes, and that's fine without any evidence. So maybe I'm a bit of a Jurassic surgeon. I would do a lymph node dissection in this patient.
So Sophocles, can I ask a question to you again? Would your opinion change if the tumor would be a luminal A or B cancer?
No. It depends on the initial appearance of the axilla. Being bulky in the beginning, I think. I don't know if anybody disagree with me, but with N2 axilla, I wouldn't go for something less than clearance in the end of the day.
So, Sophocles, as I said in the beginning, there is no one correct answer in all these cases. So thank you for your frank opinion on this. Anybody who's defending on radiotherapy to this patient? Sorry, sentinel node biopsy, sorry, and if it's turned out to be negative and you can leave the axilla intact, just raise your hand if you prefer to do that. Andreas, you have an opinion? Yeah, please.
Yeah, well, the thing is that the clinical N1s and things like that. So the actual evidence behind it is that we are more prone to de-escalate axillary surgery in the context of a CN1 disease because it is more likely to respond.
Yeah.
A CN2 that responds and you got complete pathological response has a lower risk than the C1 that remains N1 post. And the only evidence is not evidence, it is the Lucerne toolbox, and the Lucerne toolbox is an expert panel.
Yeah.
So it is a policy review. It's kind of how to start to do things.
Yeah.
The thing here is that you can defend your decision depending on whether you agree or expect a stepwise approach on that. Nothing more, nothing less. And then it has to do with the definition of inflammatory breast cancer. So for those that feel that this is an inflammatory breast cancer from the get-go, the only option is a flat chest and axillary clearance if you are not inside some clinical trial that is looking into that. But otherwise, if you've got response, then anything goes. You do not expect...
Andreas, will you agree, Andreas, that an N2 converting to N0 and doing a sentinel node biopsy on this patient after neoadjuvant chemotherapy has a higher risk of false negative results?
Not in relation to N1, because this is not a consistent finding. That's the thing. What I would have done would be that if I did not believe it to be an inflammatory cancer, I would have clipped.
And also, I would like to mention that the false negativity is not a real, relevant surrogate marker for the future axillary recurrence. We know this from the older trials. So that's why, and on the other hand, we know that from the cohort studies, although they're retrospective, but nearly 35% of those inflammatory breast cancer, especially the HER2 positives, turn out to be having a complete response after neoadjuvant systemic treatment. That's why maybe we should open a new door for these patients as well for more de-escalated surgery, probably. That's my idea, of course.
I completely agree with Bahadir on that, and I would be very, very happy for a cohort, a prospective registry or something like that to look into these outcomes. But it comes to if we discuss standard clinical practice, it is the trend is clear. If you call it inflammatory, if you do not call it inflammatory, you can attempt de-escalation surgery in any case.
Yeah, and that's the difficulty for the description of these entities. Especially this is true for inflammatory breast cancer, also for the N2. Who are N2? You should have a clear, description, and it's not really easy in real life. Theodore, please.
Yes, I agree with Andreas, and would like to ask Michalis, if we didn't have this extreme scenario that we have an N2 disease, but we had 6 or 7 lymph nodes positive, would you de-escalate or not? Or you would stick to the 4 lymph node case in order not to do de-escalation?
So the question is, if we have,
it's because it is inflammatory disease that you don't want to de-escalate? Is it because it is N2, or if it is because it is more than 4 lymph nodes?
Well, actually, it's for me the question, obviously, because I am the one who doesn't want to de-escalate.
Both.
Sophocles, please.
So as I said, I don't know what evidence we have that all these matted lymph nodes, when they melt down and when they have all these changes post-chemotherapy, they're going to maintain the structure and the anatomy to have a proper sentinel lymph node biopsy. This is what I'm saying, that we don't really have evidence, whatever we say, that the dye or the technetium or whichever will go to the right lymph nodes. This is what I said previously, but I don't disagree that there are papers about inflammatory breast cancer, and we did that in the past, that if they respond well, they can be managed, and they have PCR, they can be managed conservatively. And I agree with that, that if I had a N1, for example, case, I wouldn't mind.
Okay, Yanis.
Okay, I think that the decisions must be driven by the responsiveness of the tumor and not of the aggressiveness. In that case, I would mark 1 to 3 nodes, and after that, I would prefer to perform TAN.
Okay, thank you very much. So I think it's almost 40 minutes from the beginning. I should stop here and leave the floor to Sophocles and Mihalis to continue whether with their cases or to conclude. I don't know. It's up to you. Thank you so much. Is it okay for me to stop my sharing?
Yes, yes, definitely.
Okay.
I don't know, Mihalis, do we have time for one short case or two short cases, or shall we move to the conclusions? What
First
do you
of all,
think?
let me thank Bahadir. Thank you, Bahadir, for your presentations. Very short, very to the point. And again, you made us think. Thanks, Bahadir. I think, Sophocles, we may have some time to present one or two cases ourselves.
Okay, so let's choose the two most important. And I'll present one and Mihalis will present the other one. I don't know if you can see my screen. No? Okay, we put together a couple of miscellaneous cases just in case we didn't discuss them previously. So this is the one here. We have a 49-year-old patient, premenopausal, that she had a wide local excision and a lymph node dissection for a multifocal PT1 cancer. There were two foci under 2 centimeters and one out of 9 lymph nodes in the past. So she had wide local excision for that and then had chemotherapy, then had 2 years of LHRH, had tamoxifen, had everything by the book. And she was currently on letrozole 2.5 milligrams. Okay, so this lady had a ER positive, PR positive, Ki67 526%, HER2 score 1, that was a luminal A tumor, no family history, and otherwise unremarkable past medical history. So she presented to us with what looked like that. So there were multiple skin lesions and there was a retraction of the nipple. And in the mammogram, there was a lesion underneath. The only visible thing was a thickening under the nipple, which was considered as a fibrous tissue in the past. So we took a punch biopsy of a couple of these lesions and it showed exactly the same thing. There was a non-specific type of grade 2, ER 70%, PR 10%, HER2 score 2, but the FISH was negative. And then Ki67 was 20%. The staging for distant metastasis was negative. So we decided that she would take 6 cycles of chemotherapy before we decided what to do and run a BRCA test, which was negative. So after finishing with chemotherapy, the clinical picture was this. It was a marked clinical response. Most of the lesions disappeared. They couldn't be felt. And the one underneath the areola was still palpable, but smaller. So the question is, how do we manage these patients? Stage 4 disease with no operation, with radiotherapy only, with mastectomy plus minus axillary procedure and no repeated radiotherapy since she was irradiated 7 years ago, or with a mastectomy plus minus axillary procedure and radiotherapy, which is re-radiotherapy in this case. So difficult question, I guess, real case. And let me see, you have 10 seconds to decide what to do in this case. Obviously, in real MDTs, we have more than that. Okay, can we see the results, please? Okay, most of us would go back and do a mastectomy, remove all the skin, do something or not to the axilla, and add radiotherapy again. So I would like to ask Mr. Maragoudakis, what is his opinion about re-irradiating this chest wall?
Well, actually, I voted 3, and I will explain you the reason. First of all, the aesthetic result was not good. Secondly, radiation has failed to sterilize because this is a recurrence. It's not a second malignancy. So I don't like the idea of insisting in a treatment that has failed. I'm sorry to say that my treatment has failed. So because of the bad aesthetic result and the failure of radiation, that's why I voted for mastectomy axillary procedure with no repeating radiotherapy.
Okay, I would like to ask Dr. Angelis what his opinion about this disease. Is it a stage 4 disease or is it a local recurrence?
So it's quite difficult because obviously there's no evidence of distant disease. There's no findings on the cross-sectional imaging you've done probably. But I think with the benefit of doubt, we would be probably treating this patient as a stage 4 in terms of treatment medically. I think obviously she relapsed on letrozole, so that's a concern. And I think in this case, although we don't have any evidence of actual lesions in the scan, I think we would probably start treatment and treat her with a CDK4/6 inhibitor, and we would think about fulvestrant. That would be probably the safest approach because it's very likely that she does have a degree of microscopic disease that we're not actually seeing. But again, obviously she could potentially benefit from a local regional treatment. Again, the question is, if you don't want to do this and you don't want to take that approach of using a CDK4/6 inhibitor, you could switch to endocrine therapy, I imagine. But I think I would be quite concerned about this lady since she's developed this disease whilst on endocrine therapy in a previously irradiated field.
Well, to be honest, if you remove all that skin, most likely the skin that is left behind, it wouldn't be the one that was irradiated in the first place. So most likely you are irradiating something that was outside of the fields, of the initial fields.
I guess this is something you need to check with the previous fields, but I think the fact that she's got T4 skin disease is quite concerning as potentially having other sites of microscopic disease. So I think we would adopt a careful kind of approach with her.
Yanis.
Yes, a comment that finally this tumor wasn't from the beginning a luminal A, it was a luminal B tumor. And because it was a grade 2, not grade 1.
And can you speak a bit louder because we can't listen to you?
Yes, I'm a little tired, as all of you. The comment is that from the beginning, this was a tumor luminal B, not luminal A, because it was a grade 2 tumor. On the other hand, if you remove all that skin, you need a flap to cover the area, I suppose. If we use irradiation, we have to irradiate a skin flap from other side. I think it's useless to irradiate again healthy tissue from other side to prevent more recurrence. And the recurrence of the tumor on the skin is not exactly local recurrence. It's recurrence into lymphatic vessels of the dermis. So we have to treat it as a T4 disease, in my opinion.
Bahadir?
Well, thank you. So here, when you listen to the scenario of this patient going back to 7 years, now the patient had still a remaining tumor confined to the breast, also to the skin. So here, when I listen to our radiation oncologists, they're not so keen to radiate these patients by means of treating the patient. So there's only one option here left, that is the salvaging. This is not a treatment anymore because although you gave the chemotherapy to this patient, the systemic treatment, and the response, from the outside, from the appearance, clinically, is not complete. So what you need is now to salvage the patients. And there's only one option remains, that's the mastectomy. But that mastectomy does not mean only with the classical flaps, but also you need to resect those skin lesions as well. So this patient, and this is not for treatment, this is only for the quality of life for future, because we know that in time, whether these patients having a radiotherapy or not, and we heard from our radiation oncologist that this failed once, and the second one, we're not sure that it will affect in this case. So the only option here to maintain the quality of life for future is to remove the skin and then making a reconstruction with the full thickness flap or any kind of flap from LD flap or something like that, and then again, leave it to the systemic treatment, whether the patient would have radiation treatment or not.
Thank you very much, Bahadir. So she had a mastectomy. It was a subareolar lesion of 1 centimeter. And there was another second lesion of 0.2. All the other skin lesions disappeared. And she had 2 lymph nodes in the specimen, mastectomy specimen, which were negative. And as Yannis said, it was a luminal B, remained as a luminal B. And then, as Dr. Ageli said, she was switched to fulvestrant and CD4K6 inhibitors, and she was referred for possible radiotherapy. So all of the options were correct. And this is a paper that actually says that cutaneous metastasis is a stage 4 disease, and that we don't really have evidence that surgical excision would actually do something, but some small cases shown that maybe if they're not systematic disease, it is a good option for the patients to have a good quality of life. I think we should move to Michalis' case now. Michalis, would you like me to just have the slides here? Okay.
Yeah, thank you. So this is the last case for today. That's the good news. Everyone is tired. So hang on there. I'm pleased to say that the majority of our attendees are still there. So this is a real case. This is a 40-year-old patient who presented with a 2.3 centimeter breast cancer, basically, with a clinically negative axilla. But in staging, we found 1 liver metastasis and one bone metastasis. At that time, we did not have a breast MRI because of the metastatic disease. Core biopsy revealed a lobular cancer, hormone sensitive, but with a high Ki-67 and HER2 negative. So she was treated as a metastatic patient with CDK4/6 inhibitors and endocrine treatment and LHRH. And 12 months later, she had several CT scans in the meanwhile and PET CT scans. And 12 months later, there was no metastasis left. So the metastasis in the liver and on the bones had disappeared from the PET CT. And as for the breast lesion, it was not palpable anymore, but it was present if you really looked carefully with the ultrasound scanner. She had no family history and no other remarkable medical history. If we move on to the next slide, what I would like to ask is whether, considering that she has been stable for a year now, and with the only visible to us cancer in the breast and no metastatic sites, if there's any point to proceed to some kind of breast operation and what it would be. First choice is no operation at all because it's metastatic disease. Second choice is wide local excision with some type of axillary staging. Third, mastectomy with axillary staging. Fourth, wide local excision only. And fifth option is mastectomy only. You can vote now, please. Thank you. So most of us decided that she will benefit from some sort of surgery to the primary site. I'm very interested to hear what Vasilis voted.
So I have to say, this is a constant kind of a conversation we have with our surgical colleagues in the MDT. Most commonly, because it's our fault, we tend to bring these patients to the MDM to discuss them. And in reality, I think, although there's quite conflicting data about local regional treatment in metastatic or oligometastatic patients, and technically you could class her as one because she only has 2 sites of disease and she's demonstrated a good response. So is there a survival benefit by offering this lady surgery? I'm not convinced. But we know that there is a number of patients that potentially could. It's difficult to see and pick this out from the studies that have been done, as they have demonstrated different results, and they had a very mixed population of patients. But in this lady, I think it would be reasonable to go ahead and offer her surgery. I'm not sure what the benefit of the axillary staging would be. And I think for somebody like her, I would not be thinking that extensive surgery with, the dissection of her axilla if needed would be appropriate. So I did actually vote for a mastectomy, mostly because I think if you want to go ahead and do breast surgery, and you could argue that probably a wide local excision alone could also be an option. But I think staging her axilla would create possibly more problems, because if it comes back positive, then would you put this woman through an axillary dissection? Would that change her outcomes? No. Regardless of what you do, you would be carrying on the systemic therapy, because at some point she would relapse. So I think all of these options here are possible, but I think the least, the procedure with the least morbidity that kind of offers some potential benefit should be the option.
Bahadir, what's your opinion?
It's a very difficult question here, but I'll try to make it simple. Well, we have, 4 randomized studies, and none of them just revealed a survival advantage in this kind of a patient. Only the Turkish study just, found that there's only one subgroup who might have a benefit by having a local primary resection, and that's the only solitary bone metastasis. So looking back to these evidences in this and looking at this case, combining together, I can tell that here in this patient, still the patient, although she had a 12 month of a treatment, still have a primary tumor. And that means that she's not under control. I mean, there's no quite good response to chemotherapy. So the only concern in this patient for me is not the overall survival issue. That's the local progression. That's the quality of life. So what I would do in this patient, not do a straightforward, a primary resection or axillary, some kind of sampling in this patient, because I know that axillary sampling would not have any benefit for this patient. But is there any benefit to do a primary resection in this patient? Only in one instance, and that's the local control. So what I would do, I would follow this patient under the systemic treatment for a while. If there is any progression sign, then I would do a local excision, not a mastectomy in this patient, in order to, have the managing the quality of life in this patient. Because otherwise, doing a wide local excision or with or without axillary staging would not provide any kind of a survival advantage in this patient, depending on the all evidence so far.
Right, you're a wise man. Reminding that this is a true case. So can we move on to the next slide?
Yes, of course. Just a second.
So we did a wide local excision, and despite what we expected to find, we found a huge 7-centimeter lobular cancer with involved the one margin. All the other margins were clear. And the axilla was clear because we did the SNB as well. And you see the immunohistology are 90%, PGR 5%, with the Ki-67 very, very low. What I didn't tell you before is that the patient really pushed for surgery. And while she was on treatment, she had another experience of her mother, while she was on treatment, was diagnosed with breast cancer as well. She's quite old, her mother. And seeing what her mother was going through, she pushed for surgery. Now, considering the histology results with involved margin, the nipple margin, after a big excision, and her pushing for surgery, what would you do then? We have four options to choose from. Again, no need to do anything more. She's metastatic, etc. So stay there and do nothing, observe. Completion mastectomy and radiotherapy. Completion mastectomy only, or radiotherapy to the breast only? So you can vote now. I'm reminding you that the patient really wants to be operated upon.
That's it.
So I see the results here are divided, are split. I don't know if the completion mastectomy was voted because of the patient asking for it. Yanis,
Okay, first of all, I think that
speak up, Yanis, because we cannot hear you.
first of all, I think that we all agree that in the setting of metastatic disease, the information of axillary staging is useless. Furthermore, I would proceed with a local excision primarily for one reason: to have more information about the biology of the remaining disease, to assist oncologists maybe with more information. Anyway, after the wide excision, I think it's useless to proceed with mastectomy. And as I remind you, in the setting of M1 disease, metastatic disease. So I voted number 1.
Konstantinos, what did you vote?
You're muted.
Okay, sorry. I voted completion mastectomy and radiotherapy. Now this becomes a local control issue, in my opinion. To be honest, I had voted for a mastectomy from the start, but regardless of how it might change, like her prognosis, overall survival, this is an issue regarding local control of the disease. So I would go ahead with the completion mastectomy with radiotherapy.
To what degree you think that the patient pushing for surgery will affect our, decision? Is it important?
Well, so I think a lot of patients have, the misconception that the more we do, the better it is for them. So I think it's sometimes difficult for them to accept that it's beyond our control anymore, and that surgery. So this shouldn't really change, your decision. But now in this case, I think it would be reasonable. You have a 7-centimeter tumor there, so to do a completion mastectomy for local control. But a lot of patients, come to see us in clinic with a lump because a friend of theirs was diagnosed with breast cancer. So, or the fact that her mother, was dying from breast cancer, that can affect, their decision. But it shouldn't. It's difficult to explain that to the patient, but you need to communicate that information to them. Take their opinion into account. Obviously, she forms a decision. She needs to form an informed decision regarding what's the best for her. So I think that's the role of the surgeon, to give her all the information to help her form an informed decision. So no, it wouldn't really affect me so much. But in this case, my decision to do a completion mastectomy would be regardless of her willingness to go ahead with further surgery.
Dr. Maragudakis, would you irradiate here? Would you ever irradiate the chest wall or the breast of someone who has metastatic disease? If she's at the moment, not at risk of the local disease going out of control at the moment.
I'm disappointed with the result. Though we have a negative PET scan, the disease was just in front of our eyes. And we see that there was no response to the primary focus. So what's happening with the liver and the bone metastasis? Perhaps the disease is present at these two sites, and that's the major problem of the lady, not to irradiate or to operate the primary. I'm afraid that we have no good response, and I feel that we have to react as the goalkeeper to see where the first danger is and try to cover it. So to my opinion, it's not whether I have to irradiate the lady or if she has to be reoperated, but what's going on with the liver and the bone metastasis.
I think that was the last slide, was it? I think so.
Maybe Andreas
Yes.
wants to say something as a last comment.
You saved the best for last.
I know what Andreas will say. We shouldn't operate on her at all in the first place.
No, I'm just trying to think how do we define local control in this case, and what the pitfall may be in pursuing more surgery in order to do what, more or less. That's what my concern is. That's the only thing. I really don't have a very wise answer. I would obviously try to lay low a little bit, even if I had consented to a wide local excision, because I would not consider doing anything more. I don't know what we're looking for here. Are we looking for microscopically negative margins? And if we are, to what end? You know, that's the case for me. And I'm guessing that if we kind of, you know, go down on the slope of trying to do more extensive surgery, are we accelerating the radiological reappearance of metastatic disease that probably is there? Are we giving her more surgical stress? Are we affecting her immune response? I have these kind of questions.
Which I'm afraid we cannot. Konstantinos, you raise your hand.
No, but regarding to what Andrea said, my concern would be, so she has disease that's not responding to systemic treatment. What will happen if she comes back a year after and now it's non-operable and it's fungating? That would be my concern. Does that make sense?
It's a local control, as you said.
For local
previously.
control, yeah,
Local
yeah.
control,
But now it appears as if you have a window of opportunity to have some kind of attempt anyway, local control. But later on, it might not be even a possibility or an option. That's the rationale behind my answer and my decision.
My feeling is that as the medical oncologist will have more tools to fight the disease is going to develop different patterns of development, should I call it this way. We will be getting primaries that do not respond, metastases that respond better, bone metastases that are can be treated with local radiotherapy, liver metastases that can be treated with radiotherapy or ablation. I think that we'll get this question more and more often as we get more medications, more drugs to treat breast cancer. We cannot answer this question right now, I'm afraid.
Michalis, I think that we are already.
It is 5 o'clock. Yeah, it's 5 o'clock. It's 5 o'clock. It's 10 past 5.
So I think we should. Andreas has already started stretching here after 12 hours in a chair. My watch always says stand up and walk every hour. So I think we should do something for that. I think we should close it as soon as possible. And well, from my point of view, I would like to thank everybody for participating, all the attendees for being here for all these hours, all the panelists for contributing both in presenting cases and discussing cases. I would like to say that I'm grateful for the new people that I met through these, and hopefully we're gonna have them again in future webinars, and especially thank the old friends for being here for us and support us all the time. And I don't want to say more. I'm going to ask Michalis to do the closing remarks and everything. From my point of view, have a nice afternoon.
So I have written a brief summary of 10 pages to go through. No, that's kidding. I honestly had a summary of trying to, to sum up what we have said. And I cannot avoid seeing that neoadjuvant chemotherapy is a lot in our minds. I cannot avoid seeing that it affects our practice a great deal. I see that we are taking into account the molecular signature, so oncotype, endopredict. We discussed about endocrine treatment a lot. We discussed about extreme cases, inflammatory disease, patients with comorbidities, oligometastatic diseases, etc. But what is important is that we realized that there is no trial for every question we have. And there's no a trial for or a guideline for every problem we're going to face. That is why these meetings and MDT meetings in our hospitals and these meetings, the webinars, are educational and important because we're called to use our common sense and our experience, and if I may say, the joint experience. I feel that today I learned a lot of things. I do hope that apart from enjoyable, because I enjoyed it very much, apart from enjoyable, it was educational for you too. And I would like to thank everyone one more time for being here today, all the attendees of the meeting and all the participants, part one and part two, who found the time on a Saturday and found the time the previous weeks to get ready for today. So thank you very much. It was a great pleasure and honor to have you here. And I do hope that we'll meet somehow again in the future. I think that's it. Have a nice evening, everyone. And we'll
Goodbye,
meet each other
everyone.
again. Thank you, guys. Thanks a lot.